Can you hear me? Yeah, can you get me that it must be in his room? Where is the car? In the shower, the car. Hello. Which department? The meeting is on, you know. Yeah, I can call. Hello.
Hello, Tayo. Are you able to hear me?
Can you hear me, sir?
Oh, yes. Achha, for the host.
Can you hear me, sir?
Oh, yes, I am able to hear you. Yes. Do you? Can you hear me? Hello.
Yes, sir, we can hear you. We can hear you.
We hear you.
Right.
Can you hear me?
Yeah, I can. Baldas, Balsubrahmanyam. Hello, sir.
Yes, sir. Good evening, sir. Good evening, sir.
Good evening. Somebody is sharing the slides now?
No.
No. Then there
I
is
think,
some.
Bala sir, one slide is coming, some Zoom.
I think
Zoom is coming.
Thai 101 sir is sharing, I think.
Yes,
Komal?
sir. Yes, sir.
Because
Can you remove that?
Sir, Thai Manohar sir has to stop his sharing, sir.
Thai 101 sir has to stop his sharing. Huh?
Yes, sir. He has to.
Is he able to listen? I don't know whether he's able to listen. Thai 101 sir, good evening. I think I'll just call him and tell him.
Yes, sir.
Yeah. PN Rao sir has shown the slides? No.
yeah, no, that's why this has to go. Then only I can share my slides.
Okay, sir. Bala sir, can you call Thai 101 sir or send a message?
Yeah.
Yeah.
I have done it, sir.
Okay, I'll just share now and then show.
Yes,
Right?
Mr.
Yes.
Bala. I'm on the screen, but I can't hear anything.
But we are able to hear you, sir.
1 minute. I'll say share screen இருக்கு அது அமுக்க தொடவா
Share screen வேணாம் சார். பட் டாப்ல ஒரு மைக் பட்டன் இருக்கு பாருங்க. ஒரு ஸ்பீக்கர் பட்டன்.
Okay, is it all right now? No.
No, I am sharing now.
Sir, your slides are visible, sir. Rao sir, your slide. Yeah.
Right, okay.
Yeah. Yes, sir.
I will unshare now.
Okay.
இன்னும் அடியில் இருக்கா இப்போ வந்து எல்லாமே போயிடுச்சு ஜூம் மாத்திரம் தான் தெரியுது okay 1 minute yeah ஆமா only on laptop because I thought it's always better 1 minute
Simon sir, நீங்க பேசுறது நல்லா கேக்குது.
இருங்க you are already in another meeting. Do you want to leave this meeting and join this meeting?
Opened in 2 instruments, 2 devices. Did you open in 2 devices? You have to see.
And now I want unmute your speaker and போட்டுருக்கு இது unmute பண்ணிடவா
அன்மியூட் பண்ணுங்க சார். Sir, Simon, still you are muted.
Unmute. Tayo, unmute.
Simon sir, unmute. Yeah. Sir, speak, sir. Thai, sir. Thai, sir.
hello
Yes, sir.
can you hear me
Yeah. We can hear you. Thai, sir, we can hear you. Are you able to hear us? Yeah. உங்க ஆடியோ வருது.
இது மியூட் தானே இருக்கு.
Good evening, Ravi sir.
Good evening, Gopal.
Good evening. Hope you are safe. And
Yeah, I'm inside the room.
so are you practicing?
So closed practice for 1 month. So I'm
Oh.
practicing 1st September again.
Okay. Sai sir.
Unmute.
Yes, Bala. Yes.
Hello, Dr. Ravi.
மியூட் இருக்கு. Select microphone, same system. அதுல select a microphone, same as system, select a speaker, audio settings, leave computer audio, switch to phone audio, test speaker and microphone வருது. ஃபர்ஸ்ட் ஆப்ஷன் வந்து மைக்ரோஃபோன், ஹை டெஃபினிஷன் ஆடியோ கிளிக் ஆயிருக்கு. அதுக்கு கீழே வந்து செலக்ட் ஸ்பீக்கர்ஸ், ஹெட்ஃபோன்ஸ், ஆமா அத வந்து அது சேம் சிஸ்டம்னு வருது. அதையும் கிளிக் பண்ணிட்டேன்.
Now you are audible, sir.
He is not hearing our voice.
No.
Zoom webinar using your microphone வருது.
சார் உங்க ஸ்பீக்கர்
இருக்கு. பண்ணிட்டேனே. மைக்ரோஃபோன் இஸ் ஆன். எல்லாம் வந்துருச்சு. மைக்ரோஃபோன் இஸ் ஆன். Yeah. How do you increase the tone? This is the microphone now. This is the one. Tell audio. Okay.
I want to start an academy for doctors, for webinar techniques. No, it's really required, and also this one, Google is not only Zoom. Zoom is very friendly. There are some Cisco is there, some problems are there with that, and the Google Out, Google Hangout is there. That is also 3 or 4 systems are there. I think somebody will start some course. Better we start before somebody starts.
Zoom actually relatively user friendly, sir. Not much of
Speakers is maximum. எல்லாம் டாப் தான்.
Best thing is not to use the earphones in this one. Use because they get loose, they get the connections are there. Best thing is talk directly.
Hey sir, I can hear you.
Yeah, we can hear you. Yes, good. Right. Wonderful.
I got it. I can hear you, sir.
Right.
Ubod, can you hear me?
Yeah. We are hearing you last 10 minutes.
Oh my God! Now the first time I'm hearing you. I'm so happy. I will just give a 1-minute introduction of Dr. P. N. Rao. How do you want me to start?
No. First, Malati madam will give a present address.
Then
he'll call all your panelists. You give introduction to P. N. Rao. Sir, Rao sir will speak for half an hour.
Okay.
Then panel discussion by Murugan and you panelists, everybody can join.
Okay.
So you give introduction for Rao sir. After Malati madam speaks to you. Yeah.
Sir.
So we start at 6 o'clock, sir, sharp.
We got 10 minutes to go.
Yeah. For this troublesome only, we started 5:30. Everybody will start join.
By somehow, by all webinars and APIs seem to be going on smoothly, but somehow this is the first time I'm hearing a problem with audio. I don't know why.
Oh, okay.
Even last week, Tirunelveli API, there was no issue at all. But here, there was something went wrong. I don't know why.
Maybe some button, something. I think it is not switched off.
How is Apollo?
Apollo is okay, sir. Slowly picking up.
I know. COVID times, India number in Madras is going to go up. 3.5 lakh vehicles have entered in last 2 days.
Yeah.
3.5 lakh vehicles.
There seems to be no end for this.
More vehicle will be coming there.
Everybody now want to come to Madras now.
So they are going to open Coimbatore also. You'll get more cases.
But there is no other option. We have to get used to it.
Yeah, I know. How is it in Hyderabad, Dr. Rao?
Same. Our hospital has got 200 patients.
Oh my God.
All floors are full. But hospitals must be very, they're not uncomfortable in that sense, you know.
Yeah. Yeah.
So whatever the lockdown period was there, all the hospitals must be recovering and then going faster now.
Yes, sir.
Fortunately or unfortunately.
Only working doctors are affected, sir. Not that.
Yeah, no. Yesterday our pulmonologist got affected. Anybody asking for leave or disappearing on the day, it is indication that he is quarantine, he requires something. Suddenly, if somebody does not come, it means that he is affected.
I've stopped all procedures for some time, sir. In spite of only one stent removal I had to do. Otherwise, as far as possible, try and avoid this prophylactic band ligation.
Yeah,
all that I've stopped.
Mostly procedures only. You are so close, in spite of this pulmonologist which I'm telling, he is going with a PPI every day, and then we don't know whether it's come from outside somewhere where he went or in the hospital itself, It's terrifying, really.
In the consulting room, not only with a mask, I also have a shield.
Yeah, no. We have that 6,000 rupees filtered sheet is there. On the top of it, another thing, and we have put a big glass, about 5 feet glass, shaped glass in front of the table, in front of that one. So, and also door is open. They have to sit nearer the door.
Yes,
so,
sir.
And very problem mainly with our secretaries and then people with a nearby actually. Because they are daily we keep seeing them, they come near and then talk to you. So they are also out of the bounds. Anyhow, we have to live with it. This is going to be there. November will peak. That's what they said. Even in the month of March, somebody said it's going to peak in November.
Oh my God. Hopefully, we should get the vaccine at least the early part of next year. Then.
Yeah. Then.
Bala, what about the other panelists and?
They should be joining, sir.
Can somebody ask, because Malati madam has to come, and other chairpersons. Ravi sir is there, Ganesan and Kandasamy should be.
Ganesan, I'll call him.
Ganesan has come.
Ganesan Tanjavur.
Tanjavur. And Murugan and other panelists, Joy, Hema. Dinesh said he'll join a little later.
All have been sent the link. Should I call up, sir?
I think so.
Okay.
Dr. Rao, sir, what are you going to speak? I mean, just for introduction, what should I say? Apart from introducing you,
No, Two, journey of Nash over the time.
Okay.
And then this one, and journey of the treatment.
Treatment profile. Okay, sir.
Both the things.
Yes, sir.
This one. It is going to be a rapid fire kind of a thing. Not going into details of all drugs, so it's not possible.
Yes,
so
sir.
just a bird's view of what has been happening, what to look for in future. That's why.
So where did you do your DM, sir? Just for recollection.
MD and DM Chandigarh in both. As soon as I passed my MBBS, immediately I left for Chandigarh. I was there for 10 years.
Yes, sir.
I used to be called Hepatic Rao. At that time, I was working with Dr. D.V. Datta, and I was whole and soul in charge of the ward, consultations, and then this one. So if anybody asks, oh, Hepatic Rao ko bula do. Even in those days, my liver interest, that's what I meant,
Hello, sir.
Good evening, Hema.
Good evening, sir. Hello, sir.
How do you do?
I'm good, sir.
Bala, are we recording the program, no?
Programs are recorded, no?
Yeah. Hema, one more additional duty for you. Hema? Please check the chat box in between, and during your panel discussion, we can answer the queries, whoever asks.
Okay, sure.
Yes, sir. Dr. Joy is joining in some time. It takes a few minutes. He'll join.
Dr. Malati.
Dr. Malati, should I call up, sir?
Yeah. Because she has to start first.
Okay. Dr. Malti is just joining, sir.
Okay. Bala sir, you send a link?
Illa sir. Bala sir. In
the Chorala, but usually he will join.
Okay.
Can you call and find out if there you can send a link? Whether he's
okay.
How
Okay,
do you know
talk.
How do you know the other participants have somebody is having count of it?
Yeah.
20 வந்துருக்கு
participants பார்க்கலாம்.
20 வந்துருக்கு sir.
So check with V Bala sir only.
V Bala sir, Okay. Bala sir is joining, sir. But our panelist link anupula, sir. So he may not be seen on the screen.
Can you send the panelist link?
Sir?
Yes, sure, sir.
Yeah, it is possible. It is possible, sir. We can send.
Yeah. You can send and inform him.
Yeah. I'll do that.
Can we get his mail ID?
The other thing is, Ganesan and Kandasamy.
Dr. Ganesan and Kandasamy. I spoke to them in the morning. They received the link.
Maybe some of them using that link, I think. What we put the invitation for the participants. They may not use
Illa, sir.
Again, I also sent actually. You sent twice, I sent once.
He called personally everyone. That's good.
Understand?
He called everyone personally. That's good. Bala.
Yeah.
How is things are there?
As usual, the number of cases is really in all hospitals is going up. The routine patients are coming down. They prefer to talk to you online. So they do more teleconsultation than seeing patients.
இது லேப்டாப்ல ஜாயின் பண்றீங்களா? ஹலோ?
Yeah.
Hello, sir? Sir? Hello?
Good evening, Ganesan sir.
People are not at.
Listen, you are on.
Yeah. Are you hearing me, Ravi?
Yeah, we are hearing you, sir.
Thank you, Dr. Gopal.
Thank you, sir. Time the Malati madam has not yet come join now. Yeah. Madam, we are waiting for you only.
Oh, sorry. The problem ஆயிடுச்சு. Okay, I went through the regular then okay.
Dr. Malti, good evening.
Dr. Malti. Dr. Malti, good evening.
Good evening. We are waiting for you for your talk. You're looking nice and they're taking us to a different planet now. Astronaut.
Madam, I think we can start, madam.
Yeah. Good evening. It is indeed a great pleasure and privilege to be here. It is another virtual platform, but somehow because of this enormous strides we have made in communication, we would never have thought that we will be doing this So even though there is a lockdown, somehow we are able to meet, and more or less we are being updated in academics also. So I think we should thank, and now we will remember people whom we have missed either because of their illness, and probably we should just remember them in our prayers. And today we are having a very interesting talk. I think Ubal makes even simple topics and monotonous topics very interesting because of the title. So today we are going to another planet, and we have the astronauts. We have very important person in hepatology from AIG, Dr. P.N. Rao, who will be talking on Nash. And I think I still have his notes on hepatitis B. I think he's such an excellent speaker that whatever he tells you will just go into your mind. And welcome all our friends who have come here this evening. I know there are several talks. I've just finished listening to the this AIG and the MedIndia seminar, just the webinar we just got over. So I just hand over the mic, and I definitely wish to thank the secretary and all our members for making this event so lively, so academic, and so it is so eventful also. Thank you.
Tyson?
Yeah, okay, shall I start? Good evening, all of you. I thank the office bearers of the Tamil Nadu ISG, Dr. Malti, who is president, Dr. Upal, who is secretary, and a very dynamic secretary who brings up the most fantastic names to keep the title very, very interesting. The topic for today is about NASH and the evolution of the disease as well as the evolution of treatment. And we have no better person to talk about the same than Dr. P.N. Rao. Dr. P.N. Rao did his MD and DM at the PGI, the prestigious PGI Chandigarh. And there, I believe, he was more often called the hepatic Rao. And therefore, his interest in the liver and liver diseases started even as he was a student. And I've been with him in most conferences as a panelist, as a co-speaker, and he is an excellent teacher. And at AIG, I think he's the pride of hepatology. Now, without wasting much time, I'll hand over the mic to Dr. P.N. Rao to talk on astronauts, the evolution of the disease and treatment. Dr. Rao.
Thank you very much. Just give me a second for sharing my slides. Are you able to see my slides
Yes,
and then
yes,
hear
sir.
my voice as well?
Yeah. Go ahead, sir.
Okay. I thank you very much, Dr. Malti and Dr. Taimanwan, for your kind words. I hope I will live up to your expectations today because you have elevated to the astronauts places. And thanks to TNISG, welcome all the viewers here. And then I will go through the astronautic places here. First, I wondered, it is embarrassing to a speaker when he doesn't know what he has to speak based on the topic what is given to him, right? The word astronaut. So I was wondering whether it was a discovery or whether it's an invention, whether the word is there already or whether Ubal has invented it. And therefore, I went into but first what I did, I mispronounced it. And therefore the U, which has to come later and then come earlier here, and then I didn't find anything. So I thought, so this must be a invention, not a discovery, because I did not find it. Then I thought whether there is a NAS astronauts, whether there is a SNP polymorphism is there, NASA, there is a A to H, there is some polymorphism has occurred. Then when I put it again, I found this. Look at this here. Then I found the word, the astronauts here, very relevant to us. But also I found some other images, with the similar for the astronauts. And when I went there, and then it is a curiosity, it took me to some other places, and that is called a Nash News. And this is a Nash Community College called an NCC, and the NCC students, they refer to themselves as the astronauts. So not only that, there is an astronaut is there, and it has been a designed payload to attach to high altitude weather balloon. So we have two astronauts here. One is what I am going to speak on, and another astronaut what I have already shown you here, right? Okay. So I just take you to this one. It's very quite long ago that 1836 that the word fatty liver has been used by Thomas Edison, right? There's been something which is written here. You can go through that. 3 years later, Karl Rokitansky from Vienna observed that the fat accumulation in the liver may be etiologically related to the cirrhosis. At that time, alcohol, non-alcohol, but we know now that both can do it. Well, let's come to 20th century. There's been references in the German literature, the two which I have quoted here, that the fat indicates that the hepatic injury and scarring was identified. But the real thing came in 1880 from Mayo Clinic, and a vivid description by Ludwig and his colleagues about what now we are thinking as a Nash. And if you look at here, it is 1980 and this is 220. They produced the data on only 20 patients, whereas now we have got millions of the people who have got this one. And they clearly said it's a poorly understood, hitherto unnamed liver disease, then they called it as a non-alcoholic. Now also, it is not fully understood. We know that a lot of advances have been made, but not fully understood, but still a lot of things have to be done. And just been told, and rest of the things are all what we are seeing now. Mostly obese, many have diabetes mellitus and cholelithiasis, and simply hepatomegaly, and more common in women. That was of course slightly different, and we have got some guidelines. And currently we know of no effective therapy in 1980, and now also completely we don't have a complete effective, we can't claim that we have got an effective therapy, but rapid advances have been made as well. So you see the difference. 1980 itself, the vivid description of what we are seeing as an NAFLD has been shown. So what is in a name? We call it an NAFLD, but then recently they said that they used another term called a MAFLD, metabolic fatty liver disease. Although it's been 2020, the consensus they are arriving at, not arrived at, arriving at, but the talks have been going on for several years, that it should be linked to the metabolic liver disease. And this is the one which I am mentioning, Journal of Hepatology, and many experts, they met together, whether they said that whether it should be called an MAFLD. The importance of this one is that they are given a lean also they have included. Type 2 diabetes also they have included in the terminology of MAFLD. Look at here. The moment the MAFLD word has been used, people have already started using MAFLD. You can see the number of publications on MAFLD just in this quarter itself in 2020. And later, 1990, the clinical risk factors and the natural history has been excellently defined. As you can see, as I keep describing now, you can see how people at that time in 1990, this paper vividly describes. On the left-hand side, you got a biopsy specimen with the cirrhosis with clearly visible fat. On the right-hand side, you can see here that same after 3 years later, the fat has disappeared. And cirrhosis is still there. So that means that the so-called cryptogenic cirrhosis, when you do the biopsy, you will not find the fat, and they all could be NASH-related cirrhosis. And this was done in 1990. And later, you can see here, this biopsy specimen showing inflammation of NASH but liver architecture is normal. 3 years later, it has gone to fibrosis. That means that it is a fibrotic disease, and it has got a progressive disease was seen even in 1990 as now we know that this is a Mationic study which clearly says biopsy proven the percentage of patients with the liver related mortality and 1.7 to 11.7. But look at here, this follow-up was 8.7 years. The same people have been, the same cohort has been followed for further. Longest follow-up was nearly 28.5 years, nearly 30 years, and it is shown that the liver-related mortality in the people who have got an inflammation, NASH versus NASH, there is a difference is there. That only means that this is recognized as NASH is a progressive disease. And look at this here. This on the left-hand side, you got a clear-cut cirrhosis of liver. 5 years later, he lost 40 kilos, and then there has been reversal of a fibrosis. Such a wonderful study you've seen. 3 biopsies I have shown you here that in 1990, what we are seeing now has already been seen in repeated biopsies at that point of time by the Pioglitazone et al. Now we know that this is a clear study which shows that, and it requires that the fibrosis can, in 45% of the people, can regress, stabilize, and no worsening with if the weight loss is more than 10%. But unfortunately, the number of people who will go to that level, as you can see here, is only very small. That is the problem. The lifestyle changes, are very difficult to adopt. Then came the 2-hit hypothesis by Christopher Day from Newcastle and Freeman Hospital. And those are the people who first said that you require 2 hits. The first hit, that is accumulation of the fat, and second hit, of course, the inflammatory cytokines and then oxidative stress, right? But then there has been some controversy about that one. In 2012, this article, they said that, no, this is not a 2 hits. It is a steatosis is entirely different, and the NASH is entirely different. And there is no progression, and this is what they felt at that time. And they said that they got a distinct pathways leading to simple steatosis and NASH respectively. Why I'm saying is that we feel some people who are very obese, who have got a fat in the liver for years together, absolutely normal ALT, they don't have a NASH at all. We do here, it's not a very infrequent phenomenon. So there has to be some other thing which is to happen, and therefore they said that whether simple steatosis and the NASH are 2 different things, are always every fatty liver goes through NASH and then further consequences. Now the multiple 2 hits hypothesis is now obsolete. Then they say that is a multiple hypothesis. And you can see that all the things I will not go into any pathogenesis or a pathophysiology of NAFLD would describe that you require an environmental factor, you got an intestinal factor, you got a metabolic factor, you got a genetic factor, all put together. It is a multiple hits, the ones which is now presently, and the 2 hit hypothesis is no more relevant. Then came that it has been closely been associated with a metabolic syndrome. And you can see a linkage with the NASH, with the insulin and then HOMA by this one. And therefore the metabolic syndrome. And one of the first papers in 1990, look at here, even in lean subjects with a normal glucose intolerance, you are having an insulin resistance as detected by HOMA, not a very advanced, HOMA is a routine bedside test, and diagnosis by the ultrasound. We now know that is the reason why people say insulin resistance is first one, and the other events happen later, not the other way around, as we sometimes think obesity leads to insulin resistance. Then Dr. Arun Sanyal has gone into much more details here. These are all biopsy proven and very high-end insulin sensitivity, that is euglycemic clamp has been used. Here they clearly said that those who have got a fat and those who have a NASH, the metabolic structural, mitochondrial structural factors were present, only NASH is there, but not in the fatty liver. This is another paper, very deep paper, which is there. Then there are 2 studies are there, 28 longitudinal studies and then 19 longitudinal. See, which comes first? Is the metabolic syndrome comes first, or it is the NASH comes first, the fatty liver comes first, and then the metabolic factors. These 28 longitudinal studies and also 19 longitudinal report that non-alcoholic fatty liver disease comes first and then the metabolic factors. Although some of these things, and therefore they say that hepatic manifestation of a metabolic syndrome is outdated. But the environmental factors, if you follow the patients who have got a fat, their environmental factors are there, genetic factors are there. nevertheless, this is one of the concepts which is going on, that the primary event is fat and then metabolic factors are later. And we know that, the international diabetic criteria, it says that abdominal girth is the first and then any of the rest of the two out of the rest of the things. And this paper, I think everybody should go. The diabetics experts are coming to the field, and also they're showing a keen interest, and they're doing quite an amount of both the experimental, clinical, translational research, and also helping us in understanding the disease. This is by Dr. Kenneth Pusey, who is a very famous and then very renowned diabetologist. And then this JHEP reports, this is a progression from normal glucose tolerance to progression to the diabetes, and also some aspect of the naphthalene, and then time. I mean, this is a wonderful one. One has to go through that one to see this one. It is a bidirectional, right? Then came in 2005, the Nash Clinical Research Network has come. Now we know that it's been doing an extensive work. And all the trials, PIVENS, TONIC, SYN-CH, these are all done under the aegis of a CME. And then came in 2008, identification association of a PNPLA3 mutation, the paper which I have shown here, because that's the time when genome-wide has been done, and they have identified PNPLA3 as one of the signature, this one, for both presence of fat and also progression, and later of course it's been seen in alcoholic hepatitis, other things also. PNPLA3 is responsible. We have a small contribution here about the PNPLA3 from AAG, and we found that some differences in the north-south was there, and also in the lean subjects, one of the variant, phosphatidylethanolamine has been found out, because lean subjects still we do not know what are the factors which are responsible for the fat accumulation here, and this is what we found. And this is only just an illustration that important is patatin like PNPLA3, which brings in fat, and TMS FFT, which takes the fat out. When anything is there, then fat remains. And it's also glucose metabolism here. These are if somebody asks you what are the 4 genes which are necessary or which are important in NAFLD, these are the 4 genes which people are working, and the other 30, and people have worked extensively on these 2 and also the other ones. Then came 2010. 2010 has changed the entire landscape of NAFLD and the treatment. Now it is about 10 years now, but still it is immortalized. This study is immortal, and the PIVENS study, and also in children the TONIC study which is there, and an equivalent study like that, and both have been shown. And then we know that we've been talking about PIVENS study and pediatricians, and then they have been talking about the TONIC study. Then in 2017, there was a creation of a liver forum. And in the same year, the Flint study has come, right? The Flint study has come in 2015, and 4 years later, now we have got a regenerate study, and there is a linking is here. The proof of concept was there even at that time, that in the Flint study, primary endpoint have been arrived at, secondary endpoint have been arrived at, and also post-hoc analysis, even in stage 2 and 3 also, there has been some improvement in the fibrosis. Right. And then 2018, see, people don't want to do liver biopsy. They want to find out something else, liver biomarkers. We have got a lot of biomarkers, but still we have not arrived at which biomarker is helpful for us. And therefore, in Europe, they said liver investigation testing marker unity in steatohepatitis, that is called a litmus. And in USA, that is called the NIMBLE, non-invasive biomarkers metabolic liver disease, NIMBLE test. So in Europe, it is called something, and here also they wanted to create something. This is under the NIH Foundation. They wanted to see that very non-invasively we should be able to see. Then 2019, there is a first readout of the readout. I didn't understand what is the readout that is coming out with a lay news. Gilead, the first big Nash ends in the trash. That is a Ceylon septip has gone into the dustbin now. They have spent, and therefore it is no more used. And on the other hand, the Intercept have come up with a great hopes about the obeticholic acid, and we know that it is still awaiting the FDA approval. Well, these are all the drugs which are there. Now I have told you what has been the evolution of the disease NASH, NAFLD, over the time. I took you from 1836 to 2019 or 2020, right? And I've not gone into pathogenesis and other things because that's an entirely different thing. I just give you a bird's view. These are the drugs, you know. But then how did they evolve, right? Let us see how they evolved. 2010, I already told you that prevents, and then there is a tonic, you know, these are the two tests which are there. And 2012, and people, you know that when 2010, the prevents test, prevents has been done in the Pioglitazone has come, but it is not reaching it reached almost, but it is not reached completely for the primary endpoint. But then people, there has been 7 meta-analysis of the study here. You can see here that favors the Pio, both for steatosis, inflammation, and fibrosis, but people have not been using in non-diabetic patients because of some other skeptical things like, you know, fluid overload and then weight gain, cardiac problems, and therefore people are shying away using that one. But it appears it has done something good in a proof of concept that it does good. 2015 came the lean study, that is a liraglutide in liraglutide in people with the overweight NASH, because liraglutide is also used for reducing the weight, where the dose is 3 milligrams, and here is not this is not a diabetic dose, this is a diabetic dose, not a weight dose. And there also there is an improvement, as you can see here, and the weight also has decreased, and the ALT, there has been an improvement. But other glutides, there are several glutides are there, diabetology is there, and some of them are still are used, and we'll go to that a bit later. In the same year, the Flint study, that is obeticholic acid study, has come. And but this treatment was discontinued at that time because of increases in the cholesterol levels. But now it made a comeback again, now in the form of a recent study. 2016, if you look at it, 2010, the prevent studies was non-diabetic and a biopsy. And therefore, there was no data what happens when you give to the diabetics, the pioglitazone, what happens to diabetes and NASH. What happens to NASH when you give to these diabetics? And this is a study done by Dr. Kenneth QC. He is a diabetologist. I've already told you that 18 months outcome, as you can see, that there is a statistically significant primary endpoint as received. Resolution of the NASH was there, and also there is a one point step up improvement in the fibrosis. And this is they have used 45 milligrams, whereas in prevent study it was 30 milligrams. Right. In 2016, something else also happened, that is a golden test, golden elafibranor, right? And elafibranor versus placebo in patients with a NASH in week 12. I mean, again, as you know, that elafibranor is no more there in the list now, and there has been no difference in these people with in the primary outcome which is there. And then because diabetic people are also there, the diabetic drugs are also being used in the people who have got a diabetes and NASH, and people who have got only NASH but no diabetes also, and people wanted to see what happens to them. And this is an E-lift, that is a empagliflozin, and this is an SGLT inhibitor. Again, you will find that there is some improvement in the statistically significant improvement in both the primary endpoints and also secondary endpoints. And we see that some other flozins, SGLT inhibitors are also there. Several studies are there using different SGLT inhibitor. But I'm just taking you through the landscape of how these things have been evolved. Then Cenicriveroc, that is a center study. This is a CCR, that is a chemokine inhibitor. And absolutely, again, there is not much of a difference in these things. And when they modified the criteria, they could find some difference. Then 2019 has been a year of Nash. Actually, that's been termed as an year of Nash. As you can see here is that there are 4 studies are there. One is a vitamin E in the transplant-free survival. That is only to give more boost to vitamin E. That the transplant survival 5-year study has shown, but that is a single. Then a proof of concept study between vitamin E and then Pioglitazone in diabetic Nash. Then, of course, in the Nash, 2 of our, there's the reason rate study, and then resmetirom, the THR beta agonist. This is the one which I'm mentioning about the transplant-free survival, and also improves in the hepatic decompensation in the people with the Nash. But this is a single-center study, and this has, of course, to be confirmed. And then the proof of concept study of the vitamin E and then Pioglitazone in diabetic Nash. This is again comes from our diabetic colleagues here. As you can see here, the 3 bars are there. One is an E plus Pioglitazone, 45 milligrams. E is 400 units twice a day. And then vitamin E alone and the placebo. And you can see that their idea is that the E and then PIO is useful than vitamin E alone in people with the type 2 diabetes who have got a Nash, right? Small study, but this all indicates that the interest which is diabetic people are having in the Nash now. In fact, the ADA recommendation says that every diabetic has to be screened by the ultrasound for the amount of a fat, whereas ASLD and then still, they say that only in the high risk groups. And then now we have got a reason rate study. I mean, this, in several of the webinars we have heard about it. That is about OCA in 10 milligrams, 25 milligrams placebo. We know that now that is now available here. And we can have some discussion on this point later. And you can see that there is a primary endpoint, that is a fibrosis improvement by 1 stage has been achieved quite significantly. Higher the dose, the more is the response, and there is a difference between these two, the 23 versus 12 and then 18 versus 12. And obviously the dose should be 25, but as you know that 25 is not available in India, has not been, and this may be an off-label indication. 10 and then 5 are available here. But interesting thing is that there has been no difference in the Nash resolution, although when they take the individual parameters, they found that the ballooning and then other things have improved. When they looked at the total, they're not done. So people were wondering, when it is not improving the resolution, inflammation, how is that it is acting that and fibrosis as being resolved? Then when they saw that it is happening, that the individual sum of the components, especially the balloon degeneration, is the most important component, and that is their statistically significant improvement is there. Of course, we know that it causes pruritus in a significant number of people, and also it causes the lipid abnormalities, and that's about the reason rate. Then resmetirom, and again the THR-B agonist again is coming into the vogue now. Since it's got a theoretical thing that metabolic interferes with the metabolism of the lipids, carbohydrates, and then minerals. And here, this is again the relative change in the MRI-PDFF. It's not a biopsy study, and biopsy confirmed, but then hepatic fraction has been used here. You can see here that there has been, from the baseline, there has been a reduction in the fat of 30% in the people who are taken the resmetirom as compared to the placebo. Then 2020, we got a saroglitazar, which has been approved, which has been being used for a long time in the diabetes, and it's got a dual advantage of taking care of it. We got a study published in Liver International by a multi-centric study. Akshay Sareen and the other colleagues have Liver International, they have published there, and there are many Indian studies are available and experimental studies were there before. Then also the Indian studies have shown, some have shown CAP reduction in the CAP in the people with controlled attenuation parameter reduction have shown, ALT, ASTs have shown, and also to some extent the PAPs. And therefore that's the one which is there and then which can be. And lastly, EASL, EASL in 2020, that is yesterday only. Yesterday only EASL has started this one, and let us see what they have. I just gone through that one, but I'm just summarizing you, and therefore one can look up for in the future what to look for. And this is about the EASL here. And you can see here that a regenerate EASL analysis. They looked at the non-invasive biomarkers and the dose, and it's the same study. This is an analysis, and they have used the fibrometer, which has got age, gender, alpha-2 macroglobulin, INR, platelets, urea. I know that the fibrometer is available commercially also in India now, and also FAST and also VCTE. And when they say that there is a very clear-cut improvement in these also, apart from the histological fibrosis reversal, what has been already been demonstrated, that's about the reason rate. Some analysis has been done, and the reason rate in the EASL, there's been a post hoc analysis. What they have seen is that in these 24 months, that is beyond the 18 months, sustenance of the improvement, what has been seen, because originally the reason rate was only for 18 months. And a midterm analysis, it has to go for another 18 months and then for the final. And then in between, interim analysis have shown that, and there has been improvement in biomarkers, in VCTE and transaminases. And that is a good point, then there has been another one, as I told you, that the glyphosins, SGLT inhibitor, this ipragliflozin, some are tongue twisting names here. Ipragliflozin has been used versus an active control, and also they have also used against active control. That means pioglitazone in diabetics and GLP agonist. And there's been some fibrosis by the IPRA in 70% of them as compared to the 22%. Ballooning also has improved. So these are some of the things which we look for in people with the diabetes, where these are routinely being used. If a diabetic person has got a Nash also, how much of improvement will be there? This is an SGLT inhibitor. There is another one which is said Atlas, which is a fair 2 study. Look at it. This is what people have been talking about. That means you will not be able to achieve this by a single drug. You require, just like a multiple hit hypothesis for the pathogenesis, you require multiple drugs to take care of. You can see here selonsertib, which is AAC inhibitor, which has been given up now as a sole agent, and cilofrexar, that's the FXR agonist, that is an advancement over the obeticholic acid. And fircostat, the ASK1 inhibitor, again ASK1 inhibitor, the one which has gone already. And they have combined all these things, and then they've said at 48 weeks, there's been some improvement in the fibrosis. So that means that we are going to have, please, no. We are going to have more, I'm sorry, somebody has come, I wanted to stop them, I'm sorry about it. But then the days are there for, just like we've been seeing in HCV and then HIV, other infectious diseases, we are going to have a multiple drugs, combinations of the drugs are the ones which we are going to see. And another FGF analog, that which acts on the intestine, and that also has been shown that the statistically significant reduction and robust improvement in fibrosis and the NASH. And another one, VK2809, that is a thyroid receptor agonist. We just discussed about the THR-BA agonist just recently, and there's been an improvement. And they also shown that MRI-PDFF, it maintained beyond the period of a treatment period. That is the one which they have looked at it. So these are the ones which has been described in, which has come for oral posters, and also which I find that very significant things which are related to the previous, that's a reason rate, and then other drugs which you have in there. Well then, I've just taken you through the disease aspects, how disease has grown from 1836 to present day. And also, I've taken you to PIVEN study, which is the landmark study, which is immortalized till yesterday, what has gone on in the easel. And thank you very much. I hope this is only, I have not gone into purposefully details of all this, which is not possible. And just giving a platform for us, what to look for in future. And thank you very much for your attention. Thank you. Over. I stopped sharing.
Hi, sir. Thank you, sir.
Thank you. Tayo, unmute, Tayo.
Can you hear me now?
Yeah.
Yes.
Okay. I think that was an excellent disposition of the evolution of the disease and evolution of treatment. I think we had a perfect lift off. We went into space, we went around the moon, and it looks as though we are on Apollo 13. There is a problem, and we need to come back. And I think time alone will tell us how Apollo 13 was saved and then was brought back. And I think it's time that we put the questions to the audience, and I'm sure Dr. Rao would like to answer. My first question, Dr. Rao. Sir,
Yeah.
when you see the complications of the disease, 98% of patients with Nash, with fibrosis, would actually die of neurological problems, cardiological problems, cancer, and so on. But we are all the time concentrating on the liver, where only about 2% of the entire metabolic syndrome really has a liver problem. So don't you think that we should be having more concentration on the metabolic syndrome rather than trying to cure the liver alone?
Absolutely, Tayo. You hit on the nail, actually. And in fact, that's what's been happening for all of us. As you said, rightly said, we've been concentrating only on the liver fibrosis, inflammation, balloon degeneration, and then all these things. And it's been clearly been shown that the people with NAFLD, the mortality is more because of a cardiac and then cardiometabolic factors rather than from the NASH itself. And it goes without saying that we should concentrate on the metabolic parameters. And I hope the new name MAFLD will make us a little bit more sensitive to the metabolic factors. You are absolutely right. I agree.
Topic is open for discussion.
Is there always a lifestyle modification before you start treatment with drugs, sir? Is it compulsory that lifestyle modification has to be done? Because I think most of the trials had most of the patients had some lifestyle modification before they started on drugs.
I think it is there on for two reasons. Number one, it has clearly been shown that the lifestyle modification of the reduction in the weight of more than 10% has reversed the fibrosis in 50% of the people, and there is no progression of the disease in these people, but difficult to achieve. That is the crux, is that it is a very difficult to achieve. Hardly 5 or 10% of them will achieve. Second thing is that the lifestyle modifications will give a long way, as just Dr. Tayu has been mentioning, the cardio, neuro, other problems, lifestyle modification is going to take care of that also. Third thing is that if when you start drug, the person will think that he had got a good drug and then his everything is going to disappear. And we want to see what is the motivation. In fact, most of the time, I tend not to prescribe for about 3 to 6 months. I ask him to show, yes, you show me that you are going to reduce at least about 5%, by the next about 3 to 4 months, and then we shall see. You're over.
Thai sir, we can ask Murugan sir and the panel discussion. Everybody can involve.
Yeah. Thank you, sir, Dr. Rao. I think that was a very, very nice. It was very illuminating, and I hope as Apollo 13 returns safely, we will also return safely next year. The next is a panel discussion. I think Dr. Murugan is there.
Yeah, I'm here, sir. Can you hear me?
Yeah, I can hear you, but I can't see you.
Oh, okay. 1 minute.
Dr. Murugan, yes. I think the next topic is about a panel discussion on case discussions of Nash, and no better person than the Chief of Hepatology in Apollo Hospitals, Dr. Murugan. Dr. Murugan, please, can you take over and do the panel, please?
Sure, sir. Thank you. Okay, so it's basically a panel discussion on NASH and aspects of NASH. So the discussion is 30 minutes, focusing mainly on diagnosis and treatment for NASH, because now we have some new drugs for treatment of NASH. We were discussing, Dr. Tayu and Dr. P.N. Rao, about treating in fatty liver disease as a whole, including metabolic factors. So our focus is more on the liver aspect of the whole treatment. I am not saying that liver is the only thing that should be treated, but for today's focus, it's mainly on liver-directed therapy, especially now that we have drugs that improve NASH and maybe also improve fibrosis. So when you diagnose or deal with somebody with advanced stages of fibrosis, along with lifestyle and general metabolic treatment, definitely some liver-directed therapy is required to prevent progression to cirrhosis and complications. So the discussion today is mainly on that with a panel of hepatologist experts based on the current availability of drugs in Chennai. So I want the panelists just to focus on what you have today in India. So based on that, please give your advice. So the panelists are Dr. Hema Mala from Mayo Chennai, Dr. LVK Venkatakrishnan from PSG Coimbatore, Dr. Joy Varghese from Global Chennai, Dr. Dinesh Jodhimani from Rela Institute Chennai, and Dr. P.N. Rao is also a panelist from AIG in Hyderabad. So I hope all of them are here. I can't see everyone, but I hope they're here. So this elephant picture has been used to describe NAFLD and NASH, both for pathogenesis and for understanding the disease. It just shows that it's a multi-system, multi-etiology, multi-pathophysiology, multi-hit disease, which we are still understanding. And there is an overlap between the endocrine doctors, between the cardiac doctors and the liver doctors, and some commonalities that affect all of them, which include insulin resistance, dyslipidemia, high blood pressure, a generalized inflammation, especially in adipocytes, and a lot of fibrosis. So this is common to all, and we're still grappling. So like I mentioned, as liver specialists, let us focus on liver-directed therapy and see what is there. So I'm just going to present a hypothetical patient. It's not a real patient, but it's very typical of what we see in the OP and what we see in the community. It's a 46-year-old female who has diabetic type 2 for 8 years, reasonable control, a recent HbA1c, say it is 6.2, on some oral medication. She's also been diagnosed with hypertension for the last 5 years and is on a single drug to control the blood pressure with good control. She's had no surgeries in the past except a cesarean section, 2 children. She doesn't take any alcohol, no other significant history. There is a family history of diabetes in the family, father with diabetes and cardiac problems. So this is the background. So on further testing, her BMI comes out at 28.5. Her sugars are slightly high, with a HbA1c of 6.2. Triglyceride is 182. HDL is 33. Platelets are 195,000. AST is 58. ALT is 74. Albumin is reasonably good. She has an ultrasound, grade 2 fatty liver, hepatomegaly, and the ultrasonologist said prominent spleen. So this is the background. I'm sure we see hundreds of patients like this in our practice. So what do we do with them based on current knowledge and current available therapies? So I have 5-6 questions. I'll just start one by one. Then all of you will have a chance to answer before we move on to the next section. So I'll start with Dr. Hema. Ladies always go first. Hema, I can't see you, but I hope you're there.
I'm here, sir.
Okay. Somehow I can't see you. So what do we do next, Hema? Should we straight away start treatment for fatty liver based on the ALT? Do you want to do more tests? My point is basically we need to establish whether this patient has NASH or not, because treatment will benefit more, drug therapy will benefit more for NASH. So what do we do? What do you think we should do next? How will you proceed?
So she obviously has a fatty liver, and then she has metabolic risk factors for the fatty liver disease. So the first step would be to see, how far the liver has been affected. That is the severity of the liver disease. So the severity of liver disease we can reasonably detect first by the non-invasive markers, the blood test alone. So like using the AST-ALT ratios or platelet. In her, AST-ALT ratio is normal, so it is not giving a suggestion whether there is increased fibrosis or not. And the platelet counts were normal, I think, yes, except that there was a mild splenomegaly, which would suggest does she have a portal hypertension or does she have advanced fibrosis. So we do not know. So then we need further tests. I also use sometimes when I don't have access to FibroScan, the FIB4 or the NAFLD fibrosis score. But most of the time, the next test we order is the viral markers, because obviously there is a transaminitis, a good history to make sure there is no other drugs competing for liver injury. And then I do order a FibroScan. So the FibroScan is reasonably good at ruling out advanced fibrosis or ruling in a cirrhosis. It's reasonably good, but that is any values between 7 and 11. That is when we are not sure exactly what is the stage of fibrosis. I will order all that, assess the stage of fibrosis if there is any, or go for lifestyle intervention and then review the patient.
Thanks, Emma. So your message is you don't want to start treatment as it is. You want to evaluate a little more to be sure that there is significant liver disease before you put them on therapy. That's correct, right? Okay. So I'll ask LVK to come in next. You can comment on whatever question I asked. Plus, I will change the order. I will ask you about non-invasive tests. So Hema made the point that we want to do more tests before you start treatment. Just based on what you have in front of you, you don't want to start therapy, which many people do, by the way. As of now, I think if you take a survey, majority will start treatment with what they have. They don't do any further tests, especially in non-GI and non-hepatology practice. So I think this is a message that should go out, that when you're confronted with this, you need more tests, because the therapy we're going to use may be more specific for that. So LVK, whatever we discussed, any comments? And now if you agree that more tests to be done, let us start with non-invasive test. So what do we do? What do you do in your practice?
I don't have access to FibroScan, but we do RFE in the ultrasound, number one.
Okay.
And she definitely has all the features of a non-alcoholic fatty liver disease.
Okay.
I might be tempted to do an autoantibody, but we should also remember that autoantibodies can be positive in NAFL, and predominantly on an OPD basis, a case like this, I would look at the APRI index and a FIB4 score to probably to stratify her risk for Nash, and then probably I would offer her. I would ask her to do lifestyle modification, control her diabetes. And I am a great supporter of using statins when you have patients with NAFLD. So this is what I would do.
No, treatment will come to later. I just want you to comment.
Non-invasive test, generally we use RFE, then I use FIB4 and APRI test to stratify.
Okay. So you also agree with Hema that you need to do more tests before you start treatment, drug treatment. Hello?
Yeah, I would do viral serology.
Okay.
And
no, my question was, do you want to do more tests to assess the liver before you start treatment, or you are happy to start it? Okay.
Before I could really zero in, this is only in Nash.
Sure. Okay. So the next question is, you have, I think, Joy around. I can't see Joy also. I don't know. I can't see half the people.
Yeah, I'm
Joy,
here.
sorry, Joy. I'm not able to see.
Yeah, I'm here.
Okay. So Joy, you can comment on what non-invasive tests you prefer and why, and also comment on the role of liver biopsy at this stage of the diagnostic pathway. Do you want to give a trial of medication first? If not improved, then you do biopsy, or you're very particular to do biopsy before you start NASH treatment. Otherwise, if you're using non-invasive test, which one do you think you will choose?
So first of all, to label it as a NASH, you need to rule out all other etiology. Sometimes we are seeing the sometimes the HbA1c will turn to positive. So we have to rule out other causes. Second thing, as we have the fibroscan and the MR elastography as a tertiary care center. So the problem here with the fibroscan, as the patient is already obese, so sometimes the fibroscan wise we are not getting the, we are finding difficulty. So that time here we are referring to the MR elastography study. But if if we don't have the facilities for the MR elastography, that time the RFE, other gadgets we have to use. Liver biopsy.
Joy, you are not audible.
In the liver disease, it is the Nash. I'm not suggesting that. And apart from that, actually, the discussion management, so I can suggest my view. So liver biopsy, certainly not. So the fibroscan, if it is a difficult MR elastography, if that also difficult RFE score, that is more than enough to say it is an. Sometimes you will do the CT scan to know that sometimes very difficult if the patient have the mild splenomegaly or the intra-abdominal collaterals, everything we can see even the early stage. So the CT abdomen is also important to rule out whether it is a compensated Nash-related cirrhosis or not.
Okay, so you are happy to start treatment without biopsy. You don't insist on biopsy to start.
Yes.
Okay. Dinesh, I think just messaged me. He's trying to join.
Yeah, I've joined.
Oh, you joined. Okay. So anyway, I'll let you settle in. I'll ask Dr. Rao. So Dr. Rao, can you just give me your views on how you approach a patient with suspected NASH or fibrosis? What non-invasive test do? Do you always do a biopsy before starting treatment? Do you use a combination of tests or a single test? Just your views, sir, on this.
Thank you. I think this is our day-to-day. In this particular patient, there are two things are there. One is a diabetes of some duration, 8 years, and also she's been an obese lady. And therefore, her chances of going into advanced fibrosis and even hepatocellular carcinoma at a later stage, unless these things are taken care of, are quite significant when both the things are together are there. And it's very important that this patient, the two important things is that both the things have to go concurrence apart from the drugs. That is a very tight control of a diabetes, and also weight reduction has to be emphasized in these persons, right? That is one. And second thing is, coming to this one, her AST is also slightly higher than the ALT in a smaller range. That indicates that I suspect that she could be having some fibrosis along with the splenomegaly, if not a cirrhosis of liver. When it comes to the tests, so we've been talking about the FIB4 and the NAFLD score, all these things are which are easily available. But the problem is in assessing those kind of a thing, the middle range, that is F2, that's the most difficult where there is a misrepresentation goes off. And that has happened even with the MRI elastography also happens. And that is the reason why I have just described NIMBLE from the USA and the other one litmus from USA, both are names for finding out which best non-invasive marker will be suited to us, and it has been also been shown that if you follow an algorithmic rhythm of the non-invasive test, that is either you do one test and then do the other test, or you can do one test and VCTA, fibroscan, and your area under curve goes up to nearly 85 to 90% of the people. But for all practical purposes, although we say we don't do all these things, even APRI and this kind of a thing, we talk more about them, but we don't do. But if we can do that one, that will serve as a future. But fibroscan is one much more. I think fibroscan should be utilized more because that is a non-invasive, and also it gives a baseline value for the future. Oh, thank you. Biopsy, of course, we don't do biopsy.
Do you do any one of the scans, sir, before you start treatment, either RFE or FibroScan or MRE?
Yeah,
before you start treatment.
Of course, the FibroScan I do. RFE, if you have a RFE or fibro, both have been seen and both have been, they've seen that they are almost equal. But RFE, very difficult to, it's a narrow range, 0 to 5. Whereas this one is a 0 to 75, and that's only our mental factor. But both have been seen and both have been found to be equal. MR elastography, we know that it's a very expensive drug, very expensive, and normally routinely we don't do MR elastography.
Okay, sir.
Or FibroScan, yes.
Okay. Dinesh, I'll just brief you. We're just talking, it's actually a hypothetical patient, not a real patient.
Sure.
But basically a lady in her mid-40s with mild obesity, I would say, BMI 28, diabetic, hypertensive. Routine, some testing was done which shows fatty liver, slightly prominent spleen, and ALT is a little bit high, 94, and AST is slightly lower than the ALT. So some suggestions of fatty liver, maybe Nash. We don't know about fibrosis. Just that prominent spleen is throwing us off, and slightly low platelets, not very low, but slightly low. So the discussion is, should we start treatment for Nash straight away without anything more, or do you screen more for Nash and fibrosis with non-invasive tests, and if so, which ones? So your question would be, which one would you choose, and is there a role for combination versus single, like if you want to do 2 versus 1, and will that be enough, or you still want a biopsy before you start Nash treatment? So I just want your comments, mainly on the combination. So now the talk is on combination.
First of all, is there any pharmacotherapy for Nash? Still, I'm not very convinced that there is a pharmacotherapy properly available for Nash. So in that case, your treatment is very much limited to your lifestyle changes, that is your dietary changes and exercise. As Dr. P.N. Rao said, this lady is diabetic. She has high risk factors of liver disease progression. She's 40 plus. So therefore, the liver disease is likely to progress in her. In her, probably first thing is to say that she should get into a good lifestyle change. Because that will also
treatment we're coming in the next section. I just want you to focus
because
on
that will also improve the diabetic control and the disease progression. In terms of biopsy, certainly I wouldn't do biopsy at this stage. Yes, probably non-invasive markers we can do using FibroScan. Again, you can do APRI score and all those because platelet count is also on the lower side, so AST. So APRI score will be slightly on the higher side for her. So that might be helpful. But whatever we do, the treatment is restricted to lifestyle changes and diabetic control here. So therefore, I wouldn't do a biopsy at this stage.
Okay. So I think the consensus is that most of you would like to do more tests before starting treatment. You want more information at least. And you would use a combination of biomarker and maybe imaging marker, whatever is available to you, RFE or FibroScan. So again, hypothetically, I will try to explain what happened. Based on her values that I put up, her FIB4 comes as 1.76, which is indeterminate. It is now being used a lot in Europe as a screening test. So if the FIB4 is low, they rule out significant fibrosis and forget about it, go back to primary care and do whatever you want. If FIB4 is very high, more than 2.67, that is significant for F3, F4. And in Europe, mostly they do biopsy before they start treatment, and indeterminate also goes to the biopsy pool. So this comes as indeterminate, either to biopsy pool, to treatment, or to trials. NAFLD score is used more in the US, less in Europe, but also a useful score. It has more variables that can give you an accurate determination. Also comes as indeterminate. So there is some suspicion, but not proof that she may have Nash or fibrosis. FibroScan again comes in the middle, which is typically what you get in a patient like this. And if you take, there are different cutoffs, but roughly it comes to the middle, F2 to F3. So you're really again not sure. There's a lot of false positive in this situation. and a cap of 310, which suggests a lot of steatosis. So your non-invasive tests hypothetically is showing somewhere in the middle. Maybe there is a bit of fibrosis, maybe maybe not. So would you like to give a trial of treatment? Again, lifestyle treatment is part of the treatment, but would you like to give a trial of treatment? I'll go to the, so these are the treatment options I want you to discuss. First of all, if anybody wants biopsy, I have a hypothetical biopsy I can show you. If you don't want a biopsy, we can go for treatment. Would anybody do a biopsy in this situation? When your non-invasive test shows somewhere in between, there are high chance she may have fibrosis or Nash because of her background and risk factors, middle-aged with slightly high ALT. Would you want a biopsy? Would you want to start treatment, or just do lifestyle change and see what happens? Don't do anything. Anybody can comment.
So I think first thing is lifestyle changes. That's what I would still focus on her pretty much, because she has risk factors for disease progression. And also, it will also improve her cardiovascular mortality. That is also quite high for these patients, you know. So one shot, you can do all those things. Whereas, you know, when you talk about drugs, still there are no specific drugs for Nash. And, you know, if at all she's going to get involved with some clinical trials, yes, then biopsy is definitely mandatory for that. So apart from that, on clinical grounds, if there is no improvement with 3 months of lifestyle changes, this is what I do, lifestyle changes. If there is no improvement in LFTs, then we'll then think about biopsy to look for other possibilities. Is there anything else we are missing here? You know, so to rule out other conditions. Also, if she has severe Nash, that can prognosticate actually how she's going. So only those two indications on clinical grounds. After 3 months of lifestyle changes, if the enzymes are still not settling, but most of the time we see it settle actually. So that's what.
Anybody else want to comment on biopsy or no biopsy, or go for treatment, or do nothing? I mean, not do nothing.
Time, I think lifestyle modifications and wait, and then if she's not settling down, then plan a biopsy.
Okay. So I'm giving a hypothetical biopsy, which is very likely to happen in this situation. Either she's not improving with lifestyle change, or she's not able to do it, which again, Dr. Rao mentioned very nicely. There's a pyramid that is based on a study, I forgot the year of the study, which shows that lifestyle changes beautifully reduce fibrosis and Nash, but the compliance is between 10 to 30%. So you're going to be left with a large group of people, or bulk of your people, who are unable to do, not willing to do, whatever. So they're going to be coming back to your clinic. So a biopsy shows a score of 7, which is high, with steatosis, inflammation, and ballooning. And there is some fibrosis coming as F2 and the significant Nash. So now you have a patient with Nash, maybe early fibrosis. Obviously, you want to give lifestyle. So Dinesh, you want to tell what lifestyle changes you tell your patients? So we can just be clear on that.
Yeah, so with regards to lifestyle changes, it's about diet and exercise. But once again, there is no specific dietary pattern or exercise pattern that's been established, because the population is very heterogeneous when you talk about Nash, and in each country it's slightly different, particularly in our subcontinent. So when we talk about diet, it's about the low calorie, hypercaloric diet, rather than you know, cutting down on the fat. It's the carbohydrates. We all know that that's more responsible for causing fat and Nash. Particularly high fructose diet you should avoid. You know, that sort of dietary pattern, I would say. And recently, if you've seen papers, there are publications on intermittent fasting that's been shown to improve obesity and insulin sensitivity. And therefore, that can be adopted in Nash, provided they are not into cirrhosis. If you're into cirrhosis, then it's slightly risky to starve for 16 hours. You may get into hypoglycemia, but something we can do this in the earlier part of the disease, particularly your patient where the fibrosis is still F2.
Then, sorry to cut in. Do you focus more on diet, exercise, weight loss, or all three? Is there anything?
Yeah, so I would say is a combination of diet and exercise works. It's 70% diet and 30% exercise. Exercise, that sort of pattern works rather than the single drug. Say somebody who's eating without exercising, eating but exercising, but that's not going to work. So you have to have a good dietary pattern as well as a good exercise regimen, and at least 30 minutes of aerobic activity per day. There are some regimens like 200 minutes per week, like that. So you have to follow one of that, but it should be sustained. Another thing is these patients should be highly motivated. You can't just say patients naturally after 2 weeks of diet, they'll say they haven't lost any weight, but that's how it's going to be. And you have to have much more longer duration to assess the significant weight reduction in this thing. The paper what you quoted is actually the number of patients who go through lifestyle changes only 10%. It's in Journal of Hepatology from 2017. Yeah, that's a very nice publication on that because lifestyle.
I think they were trying to show that you need a dedicated clinic or a dedicated person.
That's right.
Counselor
you need a dedicated team,
do that.
And,
Otherwise,
somebody should follow up, and they should have a recall mechanism. So those things are definitely essential.
No one better than you to motivate, Dinesh. They look at you, they will start running. We'll come back to Hema. Drug therapy for NASH. Okay, we'll assume they do lifestyle. You still want to use drugs because there's a lot of NASH, maybe F2 fibrosis, which is the indication for treatment. I take Dinesh's point. There is no official approved drug, but we have drugs in India which are available to us to use. So at least we want to learn within ourselves and to tell the audience how to use the drug well, not to indiscriminately use it, because it's going to be used, whether we like it or not, it's going to be used. Whatever we tell on this forum today, these drugs are going to be used. So, you know the drugs available. Vitamin E has been shown in PIVEN study to have some limited role. Pioglitazone either alone or in combination with vitamin E. And like Dr. Rao pointed out, vitamin E has also been shown in diabetic NASH to work, and also in cirrhotics without decompensation. It helps to prevent decompensation. So there is still some role for vitamin E. We have saroglitazar, which has DGCI approval, even though the study is small, limited. There is an approval for use in India for NASH. And obeticholic acid is available, but not yet licensed by FDA. But the promoters of Regenerate study have been doing webinars. Most of you may have attended several webinars, where they're kind of telling you can use it off-label. So it is going to be used. So I just want you to give your thoughts on how to use these drugs. Which would you choose? Single drug, double drug, combination? Any thoughts on that? Or at least which drugs would you start with?
So in this lady, it is slightly easier because she's a diabetic. So they are going to be already on many drugs which will affect the insulin resistance. Suppose she's on metformin and she can continue that. Suppose if she's getting pioglitazone and even though there are some adverse effects, probably we will continue that. And then vitamin E, I have not been using in diabetics so far. So now there is some data for diabetics and cirrhotics, but I have not been using. Maybe we have to try further because she's a diabetic. I think one drug which probably would be useful is a saroglitazone. So even though the current approval which Indian Drug Committee has given is based on a small number of patients, but this has been there with the diabetics for quite some time. And the abstract they presented in ASLD, that is a review of large number of patients. It shows that it's a relatively safe drug. And definitely there is a reduction in transaminitis. Whether this is going to translate into long-term outcomes, we will have to wait and see. So the reduction in transaminitis will only be a possible surrogate marker. You'll have to wait and see whether it's going to make a long-term effect.
So you would start with saroglitazar for this particular patient because of her background and
it can be used.
Sure. Okay, Hema.
I think she had dyslipidemia. I don't remember the values. If she has dyslipidemia, I will use it.
I didn't put any value, but you can assume she has maybe mild dyslipidemia.
Probably
Dr. Rao, you wanted to come in?
Yeah, I wanted to say, as she clearly said that since he's a diabetic, our things are slightly made easy.
Okay.
Because most of the time, these are the first step in a diabetic NASH. The first thing is to use the metformin, which is the backbone of all the treatments.
Okay.
Next is to see whether they are an obese people or a non-obese people. If they are obese people, pioglitazone should be used because it leads, and also she being a diabetic and hypertensive, pioglitazone is contraindicated because she is likely to go into weight gain and other cardiac problems, right? Then in which case we must choose the drug which reduce the weight and which are at least neutral, right? Among all the drugs which reduce the weight are GLP-1. They are injectable. Now oral is also available now. GLP-1, they reduce the weight. And SGLT are neutral, but that also can be used. Gliptins have not been found to be useful, but they are neutral again, weight. So in this patient, I think since it's already saroglitazar has already been approved and then been used already in the diabetic, she may be already been using, but whether that will do an additional advantage or not, I do not know. But I have a very skeptic that she may be having an already grade 1 varices in the so endoscopy should be done to establish that. Even small varices will establish diagnosed cirrhosis in her.
That's a very important point, sir. So just two more questions, Subal. Venkata Krishnan, I don't know if you use drugs now, whatever is currently available. Is there any role for combination treatment, or would you like to comment on what is available and what would you like to use?
I think we have only vitamin E, pioglitazone, which has been approved by these studies. Saroglitazar has been approved by the Indian Drug Federation. The recommendation is for 52 weeks. And I have used it only in patients who are diabetic after biopsy proven NASH, and they show some sort of ballooning or some fibrosis. This is only drug which I think probably currently which we can do, but I would prefer to use it only after doing a biopsy and showing up a fibrosis and a balloon.
Have you seen any benefit, LVK, in follow-up?
I have not really had a benefit initially. We don't know how long to use this drug. The problem with
And how do you follow them up? Do you use ALT as a marker?
No, I use ALT as a marker and I look the biomarker as a marker.
Okay.
And I have not had a major experience with saroglitazar. Of course, obeticholic acid I have not used so far. But this is only drug I think which apart from your vitamin E and pioglitazone is probably available. I do agree with Dr. P. and Rao that GLP-1 is a good drug, especially when you want to reduce your weight. Can you? Okay, we are coming to combination later. Okay, this is what I think.
Okay, so I think I'll leave the final question to Joy. Joy, the only drug that has shown to improve fibrosis so far is obeticholic acid. So even though the final approval hasn't come, it is a potential drug which they are trying to speed up, I understand, because they want clinical outcome, which is going to take a long time. So they're trying to speed up, and the principal authors are saying by end of the year they should have a positive result, which means it may be officially FDA approved by end of this year. But it is available in India, and I'm pretty sure it will be used by many people. So I want your comments on the role of obeticholic acid in a situation like this where there is fibrosis. Supposing there is F2 fibrosis or F3 fibrosis, would you then prefer that, even though saroglitazar might help, but saroglitazar hasn't been shown to reverse fibrosis? They only looked at NASH. So your comments and any experience with obeticholic acid in the short time.
So before to start the obeticholic acid, we have to rule out whether the patient have the compensated cirrhosis or not. That is F4. Okay. If you have the FibroScan, if it shows the high grade, it shows the F4, better to avoid obeticholic acid.
So in this patient, we assume there's no there's no F4, so F2, F3, that range.
So yeah, so in this particular case, we can use it, the obeticholic acid. But before that, as we know already, because the obeticholic acid, all the drugs are recent drugs. But we know this background, actually, our panel members are telling lifestyle modification is the key Second is the diabetic, so the risk factor diabetic control. So as Dr. P. N. Rao said clearly, that is the GLP-1 or metformin. And this patient already has dyslipidemia. Already the dyslipidemia cases, the Pioglitazone is well approved for its many years. It has been in practice, so we can add it. So adding the obetiolcholic acid, this particular drug, we have to wait. This is my opinion. So we can follow the basic things, lifestyle, modification, and diabetic, choosing the drug and the Pioglitazone. 3 months time, we have to see whether the reversal of the ALT is there or not, and also the fibroscan also it will help. And if it is still high, that time we can try with obetiolcholic acids. So 10 milligram, and we have to carefully monitor whether the side effects also. So most of the side effects are pruritus, but anyhow, so we have to monitor.
I'll just finish with you, Joy, because we're running out of time. What about compensated cirrhosis? Do you give any treatment at all?
No, so once a NASH-related compensated cirrhosis, so we have to rule out number one, the decompensation sign, and we have to try to, the screening, the HCC screening. These two things are very important. And of course, the background, what are the risk factors? The risk factors related, the controlling effect we have to do. That's all. So risk factor control, we have to see the signs and symptoms of decompensation and the HCC screening. These three are important for a compensated cirrhosis. So the other drugs, whatever at present, it will not be that much grateful.
I think there's a lot of difference between F4 fibrosis and cirrhosis in these patients. Because the problem with the NASH cirrhosis is when you compare it with hepatitis C and NASH, if a patient has got a NASH with minimal ascites, they go down very faster when you compare it with hepatitis C. So I think when you reach a MELD of 12 or 13, you need to really work them up on your cardiovascular abnormalities and plan a transplant, because you have a very small and look for a small ascites. Even a small ascites will decompensate much faster than a HBV or HCV. I think this is what we do with cirrhosis. And I don't think any drug is really useful in patients with cirrhosis. That's my comment on it.
Sure. So thanks everyone. I'll just conclude. I think assessing risk factors and treating, everybody agrees. How to diagnose NASH and fibrosis? There is now emerging evidence, especially in this year's EASL, that 75 to 80% of the time by non-invasive tests, you can have a reasonable amount of certainty to rule out fibrosis and rule in fibrosis. There is a group of 25-30% that will come in the middle who will definitely benefit from biopsy. There is a kind of a thinking that you can formulate trials in the future and have a combination of 2 or 3 scores to have 85-90% specificity and sensitivity to diagnose advanced fibrosis. But which combination, what are the cutoffs, is still not clear. So this may be in the near future, we may have some more clarity how to use non-invasive tests to rule in and rule out fibrosis. But what is very clear is a combination of 2 or even 3 biomarkers imaging is the way to go. Ideally, 1 biomarker, 1 imaging, or 2 biomarkers, 1 imaging is the way to go to have more clarity on the extent of fibrosis without a biopsy. Because clearly to do biopsy on the entire population is going to be very difficult. Not the entire population, the entire group of fatty liver. It's going to be a huge number. And I don't think it is going to be easy to do that. But obviously, if you can do it, you'll get more information. So there is a diminishing role of liver biopsy in clinical practice, not in research. So I think this most of us agree, and many of us, when we want to start treatment, at least we start with the non-invasive test, if not a biopsy. And treatment for NASH, everybody emphasized on lifestyle modification, even though it is difficult to maintain. So I think that clearly is everybody agrees with that. And liver-directed NASH therapy, I just want to finish by saying we are just at the beginning. The message is for all the audience who are trying to treat, who are going to treat fatty liver is try to get as much information as possible before you jump into therapy. First, make sure that the patient needs treatment. If it is non-NASH, NAFLD, then you don't need drug therapy. all should have lifestyle modification. There is nothing wrong in giving a trial of lifestyle modification before you commence drug therapy. Don't take the drugs lightly. There are choice of 2-3 drugs available. If you're going to use it judiciously. Know the side effects, follow them up closely, and use one at a time. Don't use more than one at a time. Like I said, we're just at the beginning, just like HCV, and I think the next 5 to 10 years, the NASH landscape is going to change. So as and when that happens, we'll update ourselves. So I thank all the panelists, and I hope there is some useful information the audience got. I don't think we have time for audience questions. I think we'll end with that if Ubal agrees.
Thank you, Dr. Murugan. Can you hear me?
Yes, sir. Thank you.
Yeah, I just want to emphasize one thing which Dr. Dinesh Jyotimani also said. Now,
Yes, sir.
you said trial of lifestyle modification. Now, I want you to know that even if you did not lose weight, the exercise still reduces insulin resistance and progression of the disease is definitely halted. So the person should be advised that even if he did not lose weight, his lifestyle modification in the form of exercise is definitely going to halt the progression of the disease. And therefore, when the insulin resistance comes down, even if he did not lose weight, I think he should insist that he continues the exercise. I think that message should go to the practitioner.
Sure. Thank you, sir.
Yeah. Thank you, Dr. Murugan, for a very nice imaginary case, and all the panelists for giving their views. Thank you very much. If Ubald agrees, I think we'll go to the next session. I think it's a case presentation. Is the first presenter ready?
Before that, there's a secretary report.
Oh, yeah. Dr. Ubald, please go ahead with the secretary report.
Sir, my slide seen?
Yeah, you can go ahead. Yeah. Yes. Yes, Ubald, go ahead.
Before starting that, I think we have lost one of our 100-member senior gastroenterologist, Dr. Rakesh Tanton, early this month. We observe a 1-minute silence for it. May his soul rest in peace. Thank you. So we are moving into the 3rd month of our IBD study. Almost 25 centers started enrolling. We are nearing 550 cases, and the 7 centers yet to be started. I request all the centers to start so that our target of 1,500 by this another 3 months should be reached. So other projects is performance getting ready. One by alcoholic liver disease by Shanti and Venkatakrishnan sir and Prem Kumar, and Dr. Ebi started working on performer for a GA cancer. Probably next month we will be start enrolling that. And last month webinars were available on our website. Whoever missed the seminars can log in our website and go through that. And last month we had a World Hepatitis Day in spite of the pandemic, and awareness was created widespread across DDHT, Stanley, MMC, Jayanti Madam, THC sir, Murugan sir, and Radha in the GEM Hospital conducted a free hepatitis camp. I thank and congratulate all the members. And like last year, we sent the entire program and compiled it and sent to Well Hepatitis Alliance as well as WGO, and we got the certificates. And soon I'll hand over the certificate to everyone. And this is a journal we cover. We are finalized, and our first issue we are expecting it on January 2021. And the journal website is under development, and Meanwhile, whoever want to substitute the manuscript can substitute through this link. This is review.jow.medno.com/ghub. So Ramakrishna is doing an extraordinary effort, and whoever already submitted the manuscript is how much effort is taking that and reviewing the manuscript and sending the reviews and editing that. It is a huge task, and we are as a members and as a secretary, I'm very much thankful to BSR sir for his doing the wonderful job. Again, we are aiming at least 2-3 journals articles before going for our first edition. So I request more number of original articles, review articles, case series and case reports, as well as images of interest. So far, he confirmed 8 articles, and more or less that is, there will be for our first journal, it will be all the articles were accepted and ready for the publications. And next month, probably, actually, our initial idea was to have our midterm meeting in Tanjavur, but at this pandemic, this is not possible. But I requested Professor Ganesan to possibly have a webinar on September 18 and 19, that is Friday and Saturday, because September last week, pediatric conference, national conference is there. So we have a September 3rd week, 18 and 19. Each day, probably on a 5 to 8 p.m., there's a time slot we are thinking in terms of having a meeting. And the scientific content, everything will be decided by Dr. Ganesan and his team. That's the thing. And Dr. Tai, sir?
Yeah. Can you hear me?
Yeah, yes, sir.
Yeah.
So now we can now go to the presentation. I think Mahadevan PG is presenting, Mr. Dr. Harish.
Okay, I think that's his first presentation, right?
Which one, sir?
Dr. Mahadevan's presentation is the first.
Yeah.
What is his name?
Dr. Harish.
Dr. Harish. Good evening.
Yeah. Harish, go ahead. Please go ahead.
So can you hear me? Hello? 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 Hello?
Harish, you can go ahead. I think it's audible.
I think you're audible. Go ahead.
Good evening, everyone. Today we are presenting a case of gastric endoscopic submucosal dissection for a case of early gastric cancer diagnosed in a patient with post live donor liver transplantation. So patient details. Our patient is a 78-year male from MN who has nil comorbidities and underwent LDLT in 2013 for HBV related ESLD, end-stage liver disease, and HCC. And since then he was on immunosuppression with tacrolimus. In June 2019, he was evaluated for dyspepsia, and the OGD showed foci of unhealthy mucosa with features of chronic gastritis. biopsy was taken, which was suggestive of early gastric carcinoma. The details were not available. He underwent endoscopic mucosal resection in Yemen and was followed periodically after that. So he came to us in October 2019 for his regular follow-up, and we did a OGD which showed stomach showed body along the high lesser curvature showed erythematous irregular mucosal surface. NBI screening showed regular vessel pattern with gyrated surface pattern. Incisura was showing a flat erythematous lesion. Antrum in the anterior wall showed area of edematous mucosa, and biopsies were taken. So histopathological examination showed chronic atrophic gastritis with focal low-grade dysplasia and intestinal metaplasia. There was no evidence of high-grade dysplasia malignancy. H. pylori was negative. Hence, patient was discharged with anti-H. pylori therapy and advised to follow up after 6 months. In the next follow-up, in February 2020, his OGD showed a pale depressed lesion of around 2 centimeter size with elevated edges and a central depression noted at the body and antrum junction along the greater curvature. So NBI showed irregular vessels with the absent surface pattern. The antrum also showed multiple flat pale areas, which on NBI showed villus pattern with light blue crusts. So this lesion comes under the Paris classification of 2A and plus C, as it was having elevated edges with a central depression. So biopsy showed well-differentiated adenocarcinoma. In this slide, you can see there is a loss of total gland architecture with nuclear stratification, hyperchromasia, and loss of glandular architecture. So further staging of the disease was done using CCT abdomen, which showed focal thickening in the gastric mucosa in the body of the stomach, and no nodes and no liver SOL were observed. EUS was done, which showed very subtle thickening of in the layer 1 and 2, and there was no involvement of deeper layers. So a final diagnosis of early gastric carcinoma, Paris type 2A plus 2C, and TNM staging of T1A involving only the lamina propria up to the lamina propria was made. This case was discussed in the multidisciplinary team meet and was finally decided to perform a gastric ESD. So the area is thoroughly washed initially, and it was the margins were marked using dual knife. A margin of around 1 centimeter was made around the lesion. You can also use NBI if the margins are not clear to demarcate the lesion. So after the lesion was marked with a 1 centimeter margin, the submucosal plane was injected with gelfusion mixed with methylene blue. We don't usually use adrenaline. And the plane mucosa is lifted. So after incision is made along the oral end of the lesion, along the marked margins, and the incision is deepened, and submucosal dissection is carried out in the deeper plane. We do encounter large vessels while doing the dissection in the submucous plane. You can see 2 large vessels seen. So such large vessels are usually dealt with skeletonization of the vessels. The surrounding submucosa is first dissected, and we are using the choreographer to catch the vessel, and we are coagulating the vessels. So you can see the tunnel being created, which is entered along the oral end. The last submucosal fibers can be seen, which are being dissected. So we do encounter bleeding while doing the procedure. Usually, after a thorough injection, you can delineate the source of bleed, which can be controlled by using pressure by the tip of the endoscope. Then you can also use choreographer if required. So this is the last part of the dissection. You can see we are using a choreographer as it was a difficult dissection. So last part which is attached is being cut using a dual knife, and the lesion is separated. The lesion is retrieved with a using a Roth net. After removal of the lesion, we have to inspect the defect in the submucus created by the dissection, and all the bleeding spots were hemostasis achieved by coagulation. We used a detachable loop and clip technique. You can see the loop being placed, and clips are placed along the all along the margin of the defect created. So we have used multiple clips. Around 6 clips were used. So finally, using a hook, the detachable loop is tightened and the submucosal defect is approximated. You can see the final image. So biopsy revealed a high-grade dysplasia with circumferential mucosal margin, and deep margin was free of the tumor. So post-procedure, patient was kept NPO for next 24 hours. He was started on liquid diet. After 24 hours, semi-solid diet was started on the day 2, and he was discharged on the 3rd day after procedure. So early gastric cancer is an invasive cancer that invades no more deeply than submucosa, irrespective of the lymph nodal metastasis, that is T1 and NEN. So treatment options of early gastric cancer include endoscopic procedure or a surgery. So indications for endoscopic submucosal dissection, the absolute indication is for non-ulcerated early gastric cancers in the stomach, which are less than 2 centimeter size. The indications were expanded by the Japanese team later, which include non-ulcerated lesions, which are differentiated, can be of any size. Ulcerated lesion, which is differentiated up to 3 centimeters. Lesions up to 2 centimeters, which are undifferentiated. Then, like these expanded criteria have been shown to achieve acceptable en bloc resection and R0 resection rates with low risk of distant diseases. So this is a representation of the expanded criteria. The area blue, which is marked by blue, shows the absolute indication, which is less than 2 centimeter, non-ulcerated lesion, which is well differentiated. The expanded criteria are non-ulcerated lesion, which is less than 2 centimeter, which is well differentiated, greater than 2 centimeter and differentiated, and more than 3 centimeters, which is ulcerated less than 3 centimeters, and submucosal involvement, which is less than 500 nanometers of invasion. All other lesions have to be dealt with surgery. So we can see 3 meta-analysis showing endoscopic submucosal dissection for early gastric cancer involving around 4,000 patients. The en-bloc resection was achieved in about more than 90% of the cases, and complete R0 resection was also achieved in 80 to 90%. Curative resection rate was studied in only one study, which was around 80%. And you can see the mortality was 0 in all the cases, all the studies, and procedure-related bleeding was seen in around 4 to 7%, and perforation was observed around 4 to 5%. So this was a study published in World Journal of Gastroenterology in 2015, where the endoscopy surgery was compared with surgical resection. It is a systematic review of 11 retrospective cohort studies involving around 2,500 patients. 5-year survival, recurrence, and mortality, there was no difference compared with EST with surgery, and adverse event rate was high in case of surgical resection when compared with endoscopic submucosal dissection. So this was a one more retrospective cohort study, which was comparing 40 gastrectomies with 74 endoscopic submucosal dissection. Compared to gastrectomy, endoscopic submucosal ESD has less operative time and has less duration of hospital stay, and the 3-year survival rate is also more for ESD. So coming to the advantages of ESD, we can achieve en-bloc resection, wide margins are ensured, and the better specimen for histopathological examination can be obtained, and procedure itself has the local curative intent. It preserves the organ, function of the organ is preserved, better quality of life, and post-gastrectomy syndromes were very less. And you can also have shorter hospital stay, and early enteral feeding can be started. These are the various mucosal closure techniques. We used clip detachable loop snare technique. The other techniques are using a 8-ring and a clip, and clip with small mucosal incision, and clip with string can be used. Coming to the complications, short-term complications include bleeding, perforation, stricture, incomplete resection, and the duration of the procedure. Long-term complications include risk of recurrence and need for surveillance of metachronous tumors in these patients. Summarizing the case, early gastric cancer is not an uncommon problem in our setup. Screening for high-risk population is important to diagnose the stage in early stage. Early gastric cancer in a patient with post-LDLT has not been published in the literature, if not, at least in India. So ESD has both curative intent and organ preserving procedure. Complications are minimal with cost effectiveness and less hospital stay, but patient needs long-term surveillance for recurrence of the disease. Thank you.
Thank you, Dr. Harish. That was a very good presentation. I know we are running short of time, but I'll ask you one question. Can you hear me?
Hello.
Can you hear me?
Yes, sir.
Okay. Now, I understand that this patient had early gastric cancer even before you endoscoped him. Am I right? In Yemen, he was diagnosed to have EGC.
Yes, sir.
Is that right?
Yes, sir.
So, when you found the histology to be negative, don't you think you should have done an EUS at that time, or even a PET CT, and really look for the EGC than waiting for 2 months and asking him to come back?
Sir, it was, sir, in the October follow-up, when the patient came, we did a histopathological examination. That was negative for any high-grade dysplasia. It was showing only low-grade dysplasia.
Yeah.
So, considering that, we didn't proceed to PET scan or further, thinking that it was end block resection was achieved in the first EMR.
Yeah, what's the prognosis now?
Sir, hello?
Now, considering that the patient is on immunosuppressive therapy, what is the prognosis now?
5-year survival rate of 90% there for early gastric cancer, which were treated with endoscopic submucosal dissection, sir.
Yeah, but he's had a recurrence within 2 years, right?
The
first resection and Yemen.
The previous early gastric cancer was treated with EMR, sir.
Okay.
Shall I answer the question, sir?
Yeah, please go ahead, Dr. Mahadev.
Sir, actually, there is always a risk of metachronous lesions in these patients. Those are undergoing ESD for early gastric cancers. But most of them have actually chronic H. pylori infection. There is one study which is published in American Journal of Gastroenterology. Just to eradicate H. pylori therapy itself is reduce the risk of metachronous lesions or recurrences also. I think probably H. pylori was not eradicated. In this particular patient, we gave portable therapy at the time of discharge. And we lost follow-up because we did it in February. So we don't have any follow-up because of the pandemic, COVID pandemic. But always there is a risk because whenever we do ESD for early gastric cancer, this is an issue actually. This patient needs long-term surveillance. But since the patient is 78-year-old, liver transplant patient may not be a good candidate for total gastrectomy at this point in time. So even we do regular screening and do any number of ESDs will save his life.
But don't you think that you were surprised by the histology that it is adenocarcinoma? Would you have been? I mean, I would have expected to be a lymphoma, but were you surprised that it is adenocarcinoma?
So it has been reported actually. I mean, it is one of the risk factor in patients with those who are undergoing LDLT on immunosuppression. But we have searched a number of times, but we could not find any documented literature actually. So our case, we have proved histopathologically proven very differentiated adenocarcinoma.
Thank you, Dr. Mahadevan. If there are no more questions, we'll go to the second case.
Thank you, sir.
Simon, sir, we can ask the other panelists also to. Dr. Ravi, Ganesan, and Kandasamy, sir.
Kandasamy and Ganesan? Are they there? Ganesan?
Hello? Can you hear me, sir?
Yes, sir. Yes, sir.
Kandasamy, can you take over?
Hello. Congrats, Dr. Mahadevan. And it's a
Thank
wonderful presentation of removing an early gastric cancer. And actually, is there any PET scan being done for this patient?
So PET scan is not very useful because it's a very early disease which is confined to the mucosa, which may not be picked up with the PET scan. It's not even advisable for these patients.
US would have been better.
Yes.
Actually, the spread may be transgenomic, or it may be even we can have a Krukenberg tumor.
In case a patient is having, if patient have a nodal metastasis, then obviously CT will not pick up any nodes. And for
we have seen cases. The lesion in the stomach.
Hello, you're not audible, sir.
Kandasamy, you're not audible.
Yes.
Please speak, Dr. Kandasamy.
Yes, sir. Yes, Dr. Mahadevan.
Yes, sir.
Actually, even without any lesion, subtle lesion in stomach, we have seen some metastatic lesion. So before doing this procedure, I think a PET scan will be better. But removing a primary lesion, not looking into a distant, probably even a micro metastasis can have some secondary effect. Is it right?
No, we have done a CT, sir, actually. CT, there are no nodes, actually. Even very subtle wall thickening. Without involving the deeper layer, not even a submucosa, the chance of metastasis is almost nil, actually. Very only 5 to 15% is the chance of nodal metastasis. Then only will be a distant metastasis. I don't think the early malignancy confined to lamina propria will present with the distant metastasis.
Yeah, I think the very fact of ESD came into picture When your serial NBA have shown that when it's beyond, it's around the lamina propria, you don't get too much of metastasis. Only after those findings have come, people have started doing EST. So up to SM1, SM2, you can still do a EST. The chance of metastasis is very, very low. So I think the Japanese have evolved through when they found that if the depth of the lesion is only to lamina propria or even up to SM1, your metastasis is very, very high. That's how the whole EST evolved over a period of time.
Okay.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Mahadev.
Thank you.
Dr. Kansami, can you take over and conduct the rest of the proceeding?
Okay, sir. Thank you, sir. Okay.
Dr. Kansami, are you there?
Next case.
Yeah, please go ahead.
Yes, sir. I am here.
Yeah,
Can you hear me, sir? Okay, sir. Next presentation will be sir. Next presenter is ready.
Yes, sir.
Actually, is a US guided biliary drainage in obstructive jaundice by Dr. Vinod Kumar from GEM Hospital, Chennai. Dr. Vinod Kumar is there?
Yes, sir. Yes, I am here, sir.
Yeah, okay, sir. You can come out to the presentation.
Yes, sir.
You can take over to the screen.
Yeah. So, good evening, all. Sir, are you getting my screen, sir?
Yes, yes.
Yes.
Yeah. Good evening, all. My presentation for today is US guided biliary drainage in obstructive jaundice. So, first, coming to the history, she's a 70-year-old female. She's a known. She had an anthropyrotic growth with gastric outlet obstruction in early June 2020, for which she underwent post-subtotal gastrectomy with the GJ in outside hospital. Now she has presented with high-colored urine, clay-colored stools, and itching for the past 10 days. It's progressive. She also complains of weight loss. She also had fever on and off for the past 3 to 4 days. She is a known diabetic for the past 20 years on treatment. She was evaluated outside, done a CT, found to have a distal CBD compression with dilated IHBR, and she was referred for further management. So when she came to our hospital, we did an LFT. LFT showed a total bilirubin of 21 with predominantly direct bilirubin with alphas of 709. Her total counts was bit raised, 12,100. Hemoglobin is 9.1. We have done a PET CT in our hospital. It showed a post subtotal gastrectomy GJ status with ill-defined soft tissue thickening, which is metastatic, which is symptom of metastatic disease, which is infiltrating the pancreatic head and infiltrating the CBD. And we have given the option for further evaluation, but patient, since she had a major surgery 2 months back, she doesn't want any further evaluation and surgery. She wants to proceed with minimally invasive treatment. So the options to us available to relieve the jaundice are ERCP, PTBD, US guided biliary drainage, and surgery. Since she refused, it's not an option here for this patient. So we have all these possibilities. So look at the advantages and disadvantages of different techniques. ERCP is widely available, but if we cannot see the papilla in a post-GG status, we cannot do an ERCP. So it has its own restriction. Whereas PTBD is available for rescue therapy, but it has a high complication rate. Bleeding and infection are more with PTBD, and the external catheter is contraindicated if there is an ascites. Whereas US guided biliary drainage is upcoming procedure. Different approaches are possible. We can do an hepaticogastrostomy, choledochordioidinostomy, gallbladder drainage, or a rendezvous, or an antegrade stenting. And we can do the internal drainage in the same session after if the ERCP is failed. So the disadvantages are it's not widely available. Coming a word about US guided biliary drainage. It was first described by Giovanni et al. In 2001, and it has various advantages. Minimally invasive. It can be done immediately after a failed ERCP, and we can drain both intrahepatic and extrahepatic bile ducts, and post-procedural pain will be minimal to none. And comparing to PTBD, there is no external drain, so that we cannot limit patient's activities. and it has a shorter aspal size similar to an ERCP. So it's it's better than a PTBD. Although we say it's better than PTBD, like to put a study before you. This was published in 2017 comparing US guided biliary drainage with PTBD. It clearly shows this study. US biliary drainage is significantly better clinical success with lower rate of post-procedural adverse effects and fewer re-interventions, whereas PTBD requires multiple re-interventions. So PTBD is out of the contention now. So these are the various options in endoscopic ultrasound guided biliary drainage. We can do a choledochoduodenostomy if we can take the scope into the duodenum. Unfortunately, patient had a post GJ status, so this option is ruled out. We can do an US guided hepaticogastrostomy for this patient. US guided gallbladder drainage is an option, and US guided antegrade stenting is an option. Out of these three, we have chosen antegrade stenting because the main complication compared to antegrade stenting with hepaticogastrostomy is bit more. The rate of stent migration or bile peritonitis is bit more with hepaticogastrostomy than with antegrade stenting. So we thought of proceeding with an antegrade stenting. These are routine indications for an US guided biliary drainage. Basically, there are two indications. Whenever we cannot access the papilla, that's indicated. And if we can access the papilla, but we cannot cannulate, that's again US guided biliary drainage is indicated. These are the two techniques by which we can do an endoscopic ultrasound guided biliary drainage. One is an extrahepatic technique where we take the US scope into the duodenum and we puncture directly the common bile duct, put a lamps, or we puncture the left lobe of liver, segment 3 or segment 2 ducts, US guided FNA needle, and then we negotiate the wire and do an hepaticogastrostomy or an antegrade stenting. These are the two approaches by which we can do an endoscopic ultrasound guided biliary drainage. These are the various studies which can compare between the various options. What this slide shows is hepaticogastrostomy. Although the technical success rates are comparative with all these things, the complication rate is bit more with hepaticogastrostomy than with choledochoduodenostomies. Whereas if you compare PTBD with other biliary drainage procedures, definitely US guided biliary drainage is far above these PTBDs. So coming back to a case, this is a video, endoscopic video. Initially we tried ERCP, but we couldn't find out the papilla. This is the afferent loop. We have entered both afferent and deferent loop, but we couldn't access the papilla. That's why ERCP was referred for her. So then we have decided to go with an US guided antegrade stenting. Here we are looking at the segment 2 ducts. The below is the left hepatic vein. Any ducts above the left hepatic vein is segment 2 ducts, and below left hepatic vein is the segment 3. We can puncture both segment 2 and segment 3. We have decided to puncture the segment 2 ducts because if we puncture the segment 2 ducts, we can easily negotiate the guide wire. We have used the 19 gauge US FNA needle. We directly puncture the segment 2 ducts. After puncturing, we confirm by aspirating. Once the bile comes in, that means we are sure that we are in the segment 2 ducts. And rest of everything is like CM guided. So the next step is after puncturing these CM guided. This one is the metallic belt, patient's belt. So sorry for the disturbance. Then after aspirating, we inject the contrast into the biliary duct. We can clearly see the segment 2 ducts getting filled up with the common bile duct. It can show the position where we have to negotiate the guide wire. For the negotiating guide wire, we used initially 0.25 Terimo wire because the maneuverability is good with Terimo wire, 0.25 wire. So after introducing the wire into the common bile duct, we have not entered the distal part of common bile duct. After entering the common bile duct, we exchange the US FNA needle with the 6 French cystotome. Using cautery, we pierce the liver parenchyma and go into the common bile duct with the same route. You can clearly see the 6 French cystotome is in the proximal common bile duct and the wire is coiled here. Then what we do is we exchange our Terimo with a 0.25 VC glide wire, 0.35 VC glide wire, and we negotiate this wire into the duodenum. And we pass the cystotome through the wire, and once we are in the duodenum, we inject some contrast. So that means the duodenum is filled up. You can clearly see the contrast getting filled up in the duodenum. That means we are in the duodenum. Then we put the guide wire in the duodenal lumen. Then we exchange this 6 French cystotome. We introduce a 6 French EPIC uncovered Boston stent to the same route through the guide wire. You can clearly see the stent opened on the duodenum lumen, and it came up to proximal CBD. The constricted part is in infiltrated CBD, which is narrowed. The toughest part is negotiation of the guide wire into the duodenum. That's the toughest part. That we experienced that part bit tough. Once it has gone into the duodenum, we can directly introduce this 6 French catheter on the stent. And the last picture shows the contrast getting drained into the duodenum. So for this patient, bilirubin started to decrease. She was discharged after 24 hours without any post-procedure complications. So this procedure went on well, and she was discharged in almost 3 days. This procedure took around 45 minutes to 50 minutes. So what is the disadvantage of antegrade stenting? When I look at the literature, this antegrade stenting is combined with an hepatogastrostommy, because in case of stent dysfunction, bile leak may occur from the puncture site through the liver into the peritoneum. So they usually combine, they combine this antegrade stenting with an hepatogastrostommy. For example, if a stent dysfunction occurs, this hepatogastrostommy will take care of the bile, and the bile can come into the stomach. But considering it's a palliative procedure, and considering the cost, we have done one on antegrade stenting. So far, the patient is doing well. So before concluding, we all know, like US guided biliary drainage procedures are used once the ERCP fails, or if we cannot do an ERCP, we can do an US guided. But this paper, it's an interesting paper which compares an US guided biliary drainage with ERCP for first-line palliation of malignant distal biliary obstruction. So in distal biliary obstruction, they offer an US drainage procedure than an ERCP. What does this paper show? Taken 10 studies, 3 RCTs and 7 retrospective studies, total of 756 patients. What they concluded is, like, the success rate, the adverse effects, it's comparable in both groups. But the incidence of post-ERCP pancreatitis is more in ERCP group. But at present, EUS is not readily available in all the centers. So still the standard of care is ERCP. But in the near future, probably we are not surprised for this distal biliary obstruction. US drainage process can replace ERCP, and this can be in standard of care. Thanks all for your patient listening.
Yeah, the paper is open for discussion. Well done, Dr. Vinod. What was the cause of the stricture? Was it a node, or was it a stricture? Was it a tumor infiltration? What is the cause of the obstructive jaundice in this patient?
The PET CT showed some ill-defined soft tissue mass, which is probably infiltrating the head of pancreas and distal CBD. Probably an infiltrative elevation, which is compressing the CBD.
Yeah.
Your last study showed. Does the last study which you focused, does it show that you should always consider US guided biliary drainage rather than ERCP? Or it's only in the sense of when there is a outlet obstruction or you're not able to do it?
No, that's what the last study, it was published in Nature 2019. That study shows that US guided biliary drainage for distal malignant biliary obstruction has equal efficacy and equal adverse effects compared to ERCP. One advantage of doing an US guided biliary procedure is the post ERCP pancreatitis is low with this US BD than with ERCP. So probably to prevent this post ERCP pancreatitis, probably in the near future, we all may shift towards this US guided biliary procedure. So it's like in the preliminary stages, the post ERCP pancreatitis risk is less with this US guided biliary stricture, drainage procedures.
But I think this post ERCP distal biliary obstruction commonly occurs when you do a lot of treatments. If you do a selective cannulation, we have been putting stents. Probably have been putting it for the last 25 years, and we don't get much of pancreatitis in this one.
I think in this particular case, ERCP was almost impossible. They couldn't identify the papilla, so I think they had very little option but to go in for.
This is the best option because the patient had a subtotal gastrectomy, and probably because of that, US guided would be a much better option.
Vinod, you had a good presentation. I have a question. So you have punctured the segment 2 duct, and you have done a 6 French cystotomy, burned the tract. In case if the wire is not gone through the papilla, it happens sometimes. What was your plan B?
Okay, exactly, sir. I mean, initially we had this difficulty. The wire went into the proximal CBD, but it doesn't enter the distal CBD. Second, when we tried to negotiate the wire, it went to the, right system and it got down from the right system. So the next plan is, if it doesn't go to the papilla, we plan to do an hepatic gastrostomy with a geobar stent.
But you must have punctured probably at the OGGR, probably into the esophagus, because when you're puncturing the segment 2 duct,
yes,
when in US, most probably will be puncturing just close to OGGA, sometime in esophagus. It's most of the time, actually, when you have a plan B for hepatic gastrostomy, it's we prefer to use a segment 3 duct. So in case something happens, we can put a stent and come back.
Yes, sir. I mean, we initially thought of, puncturing the segment 3 duct. We all know, like, segment 2 carries a risk of pneumomediastinum and mediastinal leak. The chance of mediastinal leak and pneumonism is more with the segment 2. But to negotiate the guide wire into the papilla, segment 2 will be easy than segment 3. That's why we have punctured segment 2.
Yeah, you are lucky. I think you are lucky so that everything went on well. Looks very simple.
Yeah.
I think one of our patient, actually, we tried to put a stent. We succeeded, but finally stent was occluded with a blood clot, actually. Patient had a biliary peritonitis. There was another option. You said, actually, like both antegrade stenting and hepatic gastrostomy. There are some studies which have quoted need not to put a metal stent for the hepatic gastrostomy. So you can put a metal stent for the antegrade stenting. You can just put a plastic stent just to reduce the biliary peritonitis. That's another option, actually. So yeah, you have done a good job.
I think whenever you try to do this US guided thing, always go through the segment 3. So that's what actually Giovanni does it. He plans it as if he's going to do for a hilar block and go through the right duct and then put a stent and come out, if you're not able to get into the papilla.
Sure, sir. Are there any more questions to the presenter? If there are none, we'll go to the third case. Is the presenter ready?
Yes, sir.
Yeah, please, Dr. Naveen, go ahead.
So are my slides visible, sir?
You're visible.
Yeah. Shall I start, sir? Hello?
Yeah, start your presentation. Go ahead.
Good evening, sir. Today I would like to discuss about a case of biloma which was admitted in SIMS Hospital, Vadapalani, and how we treated the patient. So coming to the patient complaints, patient is a 60-year-old gentleman, came with the complaints of upper abdominal pain for the past 10 days, yellowish discoloration of urine and eyeballs for the past 7 days, breathlessness for the past 3 days. So coming to the present history, the pain was pricking in character with no radiation of pain, with no aggravating or relieving factors. It is associated with non-bilious vomiting, which he had 20 minutes after having food. And the jaundice, it is not associated with any history of suggestive of cholecystitis like pale colored stools or itching. There is no history of fever, no history of melena or hematemesis. It is associated with loss of appetite with a non-significant weight loss in the last 6 months. And breathlessness he had only on exertion, which was relieving on taking rest. There are no P&D attacks or orthopnea and no chest pain. No history of abdominal distension, no history of oliguria or pedal edema. No history of any abdominal surgeries in the past, no history of abdominal trauma, no history of any biliary system interventional procedures done in the past. Coming to the past history of the patient is a diabetic and hypertensive and is on regular medications and well controlled. Coming to the general examination of the patient, he is only ecteric, no pallor, no cyanosis, no clubbing, no pedal edema, no lymphadenopathy, and no scratch marks noted. And coming to the vitals, his blood pressure was 120 by 80, heart rate of 100, respiratory rate of 20, and temperature of 98.4 degrees. Coming to the systemic examination, his abdominal examination, it is soft with mild tenderness over the right and left hypochondrial region with no organomegaly, no free fluid, and no mass felt. Coming to the basic blood investigations, CBC, it showed hemoglobin of 12.7 and total count is elevated, that is 26,780. Platelet count of 3,78,000. MLAs and lipase are within the normal limits of 12 and 17. Coming to the inflammatory markers, ESR and CRP is elevated, which is showing ESR of 87 and CRP of 390. Coming to LFT, it is showing total bilirubin of 8.8 with a direct of more 4.9, indirect of 3.9, AST of 54, ALT 46, ALP 84, GGT 109, protein 5.9, albumin 2.9, and PT-NR are normal. All the viral markers are negative. So we did a CCT abdomen, which showed a fine nodular liver surface with a heterogeneously enhancing mass lesion measuring about 4.6 into 4.3 centimeters in the left lobe of liver, and multiple hypodense loculated fluid collections along the lesser curvature of the stomach and hepatosplenic space, causing scalloping of the visceral surfaces was noted. And we also found an hyperdensity at the ampulla region, CBD distal calculi. Pancreas, pancreatic duct, bile duct, intrahepatic biliary radicals are normal in size. So these are the images of the CECT abdomen. So this is the image showing the left pleural effusion. And these two images are showing the multiple loculated peritoneal collections in the lesser sac as well as in the hepatosplenic space. And the patient is also showing some nodular liver, suggestive of liver cirrhosis. And we can also see an heterogeneous mass over in the left lobe, which is not typically characteristic of HCC. And we can also find some CBD calculi at the ampulla region. So the differential diagnosis at this point, we kept it as cirrhosis with atypical HCC with pyogenic abscess, or cirrhosis with atypical HCC with rupture of the tumor, cirrhosis with spontaneous biloma secondary to common bile duct calculi, or cirrhosis with spontaneous biloma secondary to hepatocellular carcinoma. So we did an alpha fetoprotein which came out to be as 2.58 nanograms per ml, which is normal. So then we proceeded with an ultrasound guided percutaneous aspiration of the peritoneal fluid collection, which showed a bilious fluid was aspirated. Around 300 ml was aspirated from the lesser sac and 100 ml was aspirated from the other side. And the cytology of the fluid showed suppurative inflammation with no malignant cells. And this is the histology picture which is showing neutrophilic predominant cells. And the culture also isolated Klebsiella pneumonia. So at this point we diagnosed it as a spontaneous biloma, which is an infected also. We kept it as spontaneous because there is no history of any abdominal trauma, no history of any biliary interventions or any other such as surgeries in the past. So we still don't know what is the lesion in the left lobe of the liver. So what next? So then we decided to do an MRI so that we can determine the exact site of the leak of the bile, as well as we can appreciate what is the left lobe liver lesion, which is not still addressed. So, but MRI could not be done for this patient because he had breathing difficulty and he was unable to hold his breath. So then we decided to do an ERCP, was attempted with a plan to stent the bile duct to prevent recurrence of the biloma. But unfortunately, cannulation was also successful. So needle papillotomy was done and planned for repeat ERCP at a later time. So then we wanted to know what is the lesion in the left lobe of the liver, the heterogeneous lesion. So we proceeded to diagnostic ultrasound guided percutaneous biopsy of the left liver lobe, which was done and it was sent for histopathological examination. So the histopathological examination of the liver lesions came to be as well-differentiated hepatocellular carcinoma, which is showing in this image, which is showing the malignant hepatocytes are arranged in a trabecular pattern. And when we stain it with a reticulin, and it doesn't stain, which is also a characteristic feature of hepatocellular carcinoma. So as the patient had a solitary hepatocellular lesion, which is less than 5 centimeters with preserved liver function and performance status of 0, TACE was done using 30 milligrams of doxorubicin and ethiodized oil. Even the patient had a TACE procedure, he still persisted to have pain requiring fentanyl infusion to control his pain. So we did a repeat CT after the TACE procedure. This is a post-TACE procedure, which is showing the heterogeneous liver mass. And we also, the same old distal CBD calculi, which is around 18 to 9 mm was noted. So again, we did an ERCP, which was done subsequently. This time we successfully cannulated and a pigment stone was extracted and a double pigtail plastic stent was placed in the common bile duct. So these are the images showing the pigment stone was extracted and a pigtail was placed, deployed into the common bile duct, and this is the fluoroscopic images showing the pigtail. So after the procedure, his pain decreased and the left improved to 1.4 total, 0.9 direct, 0.5 indirect, AST of 309, ALT of 192, and ALP of 200. So he was advised sorafenib and he was discharged. He came to our OPD after 10 days and with no fresh complaints. And later again, he didn't come for the follow-up. Coming to discussion. Spontaneous perforation of the biliary tract and biloma formation is a very rare entity. So majority of the cases of the spontaneous biloma are associated with choledocholithiasis, in which our case we had a patient with choledocholithiasis. And the most frequent reported sites are anomalous hepatic ducts or confluence of the cystic duct with common hepatic duct or gallbladder with common hepatic duct. So usually the bile gets encapsulated within the omentum and mesentery, which prevents generalized peritonitis, in which our case we didn't have any peritonitis except by forming bilomas. And one more thing, bile is sterile. So many patients remain asymptomatic for weeks until the bile becomes super infected, in which our case our patient also had an infected biloma where Klebsiella pneumonia was isolated from the culture. And association between hepatocellular carcinoma and spontaneous bilioma has not been reported in this literature. So in our case, with the patient is having both hepatocellular carcinoma as well as choledocholithiasis. So confounding factors, we don't know exactly what is the cause, but the literature is showing that most of the patients with spontaneous biloma will have choledocholithiasis. Till now, HCC, whether it is cause or not, it's still unconclusive. Thank you.
Yeah, that was a very nice presentation, Dr. Navi. The topic is open for discussion.
Why did you use sorafenib?
Sir, we diagnosed to have a hepatocellular carcinoma.
But is it resectable, or you think you can do something else for the?
Sir, we gave him the options of liver transplantation, surgery, and medical management. Sir, he chose for he wanted time to decide later, so we just added sorafenib and discharged him, sir.
If the endoscopy show varices, he looked as a nodular liver, no? Status, performance status 0.
Yes, sir.
Will he be a candidate for surgery and transplant?
Sorry, sir?
Is he a candidate in future for transplant?
Yes, sir.
But he's not willing.
Yes, sir. I mean, he asked, he required time to decide, sir.
What is his viral status? Was it hepatitis B, C?
Vital markers all are negative, sir.
Are there any more questions to the presenter? Well, if there are none, I think we'd like to thank Dr. Naveen. Good presentation. Well done.
Thank you, sir.
Dr. Upal, are there any more cases for presentation? Is that the last case?
I think that's the last case, sir.
And you can go ahead now.
No, sir. You want to conclude anything? Because the forts, they are organizing these things. They want to give a vote of thanks. You want to say anything? And
no, I think it was I think we should thank the Tamil Nadu chapter of the Indian Society of Gastroenterology for doing this excellent meeting. This virtual meeting, I think, was very good. It had a large content, 3 very nice cases, all therapeutically very well done from 3 different institutions in Chennai. I think Dr. Abbar, we can bring the meeting to close with 4 of them.
Thank you very much, sir, for giving the opportunity to participate in this webinar, sir, especially the football. And right from the southern corner, we are able to, and it will be beneficial for our postgraduates also. Thank you very much, sir, and we will continue the same thing in future.
Yes, Dr. Upal.
Thank you, everyone.
Thank you, sir. Dr. Bala, sir, is there anything, sir?
Yeah. Good evening to all. I am Bala Subramanian, General Manager Marketing with Forts. You all know about Forts is a leading pharmaceutical company from Chennai, ranked among the top 50 companies in India, and we have many innovative brands in GI therapy. To name a few, Sucrafil, Sucrafilozil are our flagship brands with Repro IBS, Tocofil, Udimarin, Oxyroot CD, and other brands to offer. So I take this opportunity to thank Dr. P.N. Rao, though he has left the webinar, for obliging to be part of this webinar despite his busy schedule, for his wonderful lecture on NASH. I thank the chairpersons, Dr. Thai Manohan, Dr. Ravi, Dr. Kandasamy, and Dr. Ganesan. I thank Dr. Venkatakrishnan, Dr. Joy, Dr. Dinesh, and Dr. Hemamala for the wonderful panel discussion. And I thank Dr. Murugan for moderating the panel discussion. I thank all the presenters. I also thank all the participants for making this webinar a grand success. Finally, I thank Dr. TNISG and Dr. Ubal Das for giving Forts an opportunity to be part of this wonderful scientific session. Thank you and good night. Thank you all.
Bala sir, anything
Thank
you
you,
want
sir.
to say? Bala sir?
Ubal, well done, well done. Every month you keep improving the standard of our meeting. And even this COVID pandemic, still we are able to make people happy in the form of a scientific one. Thank you very much and keep doing it. Let me thank the Force Bala for the involvement what he has. Thank you, Bala.
Thank you, sir. Thank you, sir.
Thank you,
Thank
sir.
you,
Thanks,
Ubal,
thanks.
sir.
Thanks, on and off.
Good
Yeah,
night.
thank you.
Good night,
Good
all.
night, sir.
Thank
Good
you.
night. Good night. Thank you, Dr. Ubal and Dr. Bala and everyone. Thank you.
Thank you, madam.
Thank you, madam. Thank you.
Thank you, madam. Thank you so much.
Mm.